Huh? Before we move forward, let's together pause to reflect on the cost of conflict that extends beyond the data and evidence we share in forums like this. In Gaza, our MSF colleagues carry out medical care under extraordinary strain, sustaining care, collecting knowledge, and bearing witness in circumstances that challenge the very foundations of health and humanity. Many of them and their loved ones have been killed in this genocide. On September 16th, our colleague Hussein al-Najjar died in Gaza from shrapnel injuries caused by an Israeli airstrike near his tent 5 days earlier. Hussein's sister-in-law and nephew were also injured in the same incident. This is not a tragic incident. It's yet again a demonstration that there is no safe refuge anywhere in the Gaza Strip. Hussein was passionate and loved life. He was a husband and a father to 3 young children and was eagerly looking forward to seeing his brother, whom he supported financially, finally graduate from medical school in Egypt. Hussein is the 13th MSF colleague to be killed since the war started in Gaza. We are outraged that the military violence continues to kill our Palestinian colleagues. The pursuit of science and the delivery of care are never abstract. They are rooted in the lives, dedication, and sacrifices of the people on ground. In honor of Hussein al-Najjar, our other colleagues and medical workers, in recognition of their courage and contribution, I invite you to join me in 2 minutes of silence. Thank you. Let us carry forward the dedication of our colleagues in Gaza through the work we share today. We'll return to the program now. I now invite on stage Parthasarthi Rajendran, Executive Director, MSF South Asia, for welcome remarks. Nadeem? Nadeem. One second.
Good morning to our distinguished guests, esteemed colleagues from the global medical and scientific community, and most importantly, to the community health workers, patients, and partners who are at the heart of our work. A warm welcome to MSF Scientific Day 2025. We gather at a critical moment, a moment where the very idea of truth is under assault, where a devastating wildfire of misinformation and disinformation spreads faster than any virus, eroding trust, endangering lives, and challenging the core principles of evidence and reason. In this fractured landscape, the language of science is often dismissed, while the loudest and simplest lie go viral. This is not an abstract debate. It is a life or death crisis for global health. It kills vaccination campaign. It undermines public health measures. It isolates the vulnerable and empowers the deadly. We have gathered here in Colombo under a theme, and here is to break down these walls, because we cannot defend science from the outside. We must embed it within the community. True innovation is not developed in a sterile lab and handed down. It is forged in partnership with those who will use it. This is about making scientific standards stronger, more robust, and more trustworthy by including the most critical vulnerable, that is human context. The most elegant scientific solution is worthless if a community has been poisoned against it by lies. Conversely, a community's adaptive response to a crisis holds a genius that our textbook miss. The genius born out of necessity and trust is important. Our responsibility is to listen to that wisdom, to learn its logic, and to lead by helping to translate it into a scalable, evidence-based care. This is why our partnership are a powerful statement. We are deeply grateful to our academic partner, Faculty of Medicine at the University of Colombo, a pillar of medical excellence for over 150 years, who exemplify the rigor of scientific inquiry. Equally, we are honored to collaborate with Sarvodaya Shramadana movement, which has empowered over 15,000 Sri Lankan communities through participatory development. They represent the indispensable wisdom of community engagement. Together, these partnerships bring the alliance we need, the scientific rigor married to community trust. This is the ultimate antidote to misinformation. Today, our intention is not merely to discuss communities, but to listen to them. Our program is designed to elevate the perspective, from oral presentations on community-centered innovation to a compelling exhibition sharing the human stories behind the data. We will highlight solutions from portable operating theaters to digital tools that impress not only through technology, but by being anchored in evidence and shaped by real field needs. Our challenge is very clear. We must listen not just to stories, but for the data within them. We must learn not just from studies, but from the deep well of the community experience. We must lead not with assumptions, but with evidence that is undeniable, because it builds together. In a world of dangerous lies, we must make the truth more compelling, more relevant, and more human. Let us ensure that the future of the global health is written not by algorithms spreading disinformation, but by people, scientists, and communities, co-creating a healthier, more equitable, and truthful world. Let us ensure that a language of science in global health is never complete without the voice of the community. Thank you and welcome again.
I now invite Professor Vajira Disanaika, Dean, Faculty of Medicine, University of Colombo, for opening remarks. Please, sir.
Colleagues, friends, distinguished invitees, ladies and gentlemen, good morning. It gives me great pleasure to say a few words at the inauguration of the MSF Scientific Day.
Yes.
The Faculty of Medicine of the University of Colombo is very happy to be a co-partner of this conference, and we've been the academic partner with MSF for this year. Last year, I was approached by MSF to explore the possibilities of collaborating with our faculty on the academic activities in this year, and I was very happy to do that. There are multiple reasons for that. First, of course, is the fact that we have multiple capabilities in our faculty, going beyond the biomedical model, engaging society at large. And we were also in the process of setting up centers of excellence that could engage the work that you do in various ways. We have a center for health systems, policy, and innovation, which is working on diverse fronts, going beyond the usual medical faculty's confines, and working on health systems policy, strategy, planning, economics, as well as innovation, cross-cutting beyond across the board. Then we have also a Center for Planetary Health that is working on the entire concept of One Health and giving light to that and introducing newer concepts that are being taught of in medical fields but not in medical schools, and introducing them to our up-and-coming doctors and other health professions that we are training, so that they are exposed to the wider determinants of health. Then we have a Center for Meditation Research that is working on bringing about mental resilience in the community at a time when the world is in turmoil. And I can tell you, when we set up the Center for Health System, Center for Meditation Research, and we started publishing how meditation acts on mental resilience. One of the visits that I had was from the Director of Research of the US Naval Command based out of Singapore. He came and said, "Professor, we send soldiers to battle, but when they come back, they have to get integrated to society, and they come with very disturbed minds, and can you help us with these people. So the conflicts that we see in the world today are thrust upon us by people who have no control over them, and there are victims of that everywhere. So we, as a Faculty of Medicine, through our centers, are able to engage MSF in various fronts. And those were just 3 examples. There are many more. And we'd like to, unleash our fullest potential together with MSF so that we can take the MSF's South Asian region to greater heights in terms of the work that you do, and globalize the work that we do in this region, because South Asian region definitely will be the global leader, not only in, as we see in the economic front as we go on to the future, but also in the social and development front. And we will be able to lead the world through the work that we do. With those words, let me thank MSF for reaching out to our faculty and engaging us and inviting us to be your academic partner this year. Let me thank our colleague, Dr. Vinya Ariratna. The work of the Sarvodaya inspires us, and we continue to engage him in various ways. I'd also like to thank our colleagues in the Ministry of Health, represented today by Dr. Sridharan, the Deputy Director General of Planning. We are very happy indeed to be partnering with his entire team. Linda is here, Janaki is here, and of course, Susie, who was there before, is here, and Sunil, everyone, the entire planning and development team in the ministry is here today, so we are happy that they are all here and we can continue to engage them. And of course, our colleagues from the Sri Lanka Medical Association, Dr. Surantha Pereira, President, and the President of the College of Community Physicians, Dr. Kapila Jayaratna. All of them are here, so we have the entire, leadership, as it were, leading some of the development work, or most of the development work that's happening in this country in the health and social development sphere here. And I'm really happy that we, as a group, the Faculty of Medicine, Sarvodaya, MSF, have been able to partner with all of you to highlight the issues in the health sector that we need to highlight so that they have a voice. So with those words, thank you very much for the invitation to speak at the inauguration. I look forward to engaging with you throughout the day, and I look forward to engaging especially with some of our development partners who are here. And I hope that all of you who have come from abroad will enjoy the next few days that you spend in this country and take fond memories back home. Thank you very much.
I would now like to invite Dr. Vinya Ariyaratne, President of Sarvodaya Shramadana Movement Sri Lanka. Yes, please.
Good morning. Executive Director of MSF South Asia, Partharthi Rajendran, Vidya Jyoti, Professor Vajira Disanayaka, Dean of Faculty of Medicine, University of Colombo, Dr. Sridharan, Deputy Director General Planning of Ministry of Health, and all the senior officials of the Ministry of Health. Dear colleagues, friends, ladies and gentlemen, it's both an honor and a privilege to stand before you today as the President of the Sarvodaya Shramadana Movement at this very significant gathering that focuses on the theme that is very close to our hearts: Community Voices in Healthcare Innovations. This event, MSF Asia 2025 Scientific Days, is held in collaboration with the University of Colombo Faculty of Medicine and Sarvodaya Shramadana movement as the community partner reflects a shared commitment to advancing healthcare through inclusive, community-centered approaches. The theme of this year's conference resonates deeply with the core philosophy of the Sarvodaya movement, which I represent, which has always believed in the intrinsic worth and the power of communities as vital agents of change. Historically, healthcare approaches that neglect voices of those directly affected often fall short of their potential to create lasting, meaningful impact. We have seen time and again that true innovation in healthcare emerges when the community voices are heard, respected, and also integrated into the decision-making processes. Communities are repositories of rich indigenous knowledge, cultural practices, and lived experiences that can significantly enhance our collective understanding of health and well-being. Their insights can illuminate unique challenges and inspire contextually relevant solutions that are sustainable and accepted by those that are meant to serve. In our journey towards health equity, it is imperative that we move beyond viewing community members as mere beneficiaries or passive recipients of health services. Instead, we must see them as active partners, collaborators, innovators, and co-creators of health solutions. This paradigm shift not only enriches our strategies but also fosters trust, ownership, and empowerment, which are essential ingredients of for the success of any health intervention. Today, I request and I urge all involved, the researchers, healthcare professionals, providers, policymakers, community representatives who are here today, who gather from whole of South Asia and elsewhere, let's create spaces for dialogue where these voices are amplified and integrated into research, policy making, and service delivery. Not only such collaborative efforts can we develop innovative, equitable, and culturally sensitive healthcare models that truly meet the needs of all segments of our society. Therefore, I would like to express my heartfelt appreciation to MSF Asia, South Asia, for inviting me and Sarvodaya to be a partner at this important conference. And we can see a great progress towards partnerships that we all would like to build in addressing both local, regional, and global challenges. Together, let's forge a path towards a healthier and more equitable society, one where every voice counts, every community is empowered, and every innovation is rooted in the real life experiences of those whom we aim to serve. Thank you very much.
I would now like to invite Dr. S. Sridharan, Deputy Director General Planning, Ministry of Health, Sri Lanka.
Thank you. Thank you, and good morning to you all, distinguished guests, friends, ladies and gentlemen. Protocol observed. First of all, I wish to thank MSF for inviting me for this summit. So, a couple of months ago, delegates of MSF came and met Secretary Health and told that South Asia office will be established in Colombo, and they need Ministry of Health support and wishes. So at once Secretary told we'll help you, and then I asked them in what area they're going to focus, mainly on emergency, quality of care, and climate action. And immediately now you all know that Ministry of Health is our planning unit and policy unit. They are working on this 2026-2035 this health policy and health master plan. So immediately I told my directors, this please contact MSF. So they will support us with related to these areas, and immediately they contacted. I'll come to that later. And I understand that MSF is an international medical humanitarian organization working in disaster and conflict affected settings across 70 countries in the world, and South Asia you have 14 countries. And they provide essential medical care and strengthen health systems and the community-led action for healthcare delivery, quality of care, climate action, and AMR, etc. So in the past, MSF provided essential medical care during tsunami and civil war 2009, during 2009 in Sri Lanka. At present, MSF South Asia Regional Office is stationed in Colombo, as I told earlier, looking out operations across the South Asia region, that is 14 countries altogether, South Asia and Central Asia. And now, at presently, Ministry of Health and MSF are collaborating in few areas, and MSF is contributing to the ongoing health policy development process under the thematics of climate change and quality of care. MSF recently hosted INGO and NGO sectoral meeting for National Health Strategic Plan Development Process of MOH. And in April, MSF, with the technical support of different stakeholders, including the Ministry of Health, conducted a regional climate and health roundtable in Colombo with participation of over 70 participants from more than 7 countries. MSF ready to expand in collaboration with the Ministry of Health in the areas of climate change, emergency preparedness, and quality of care, etc. So this today's MSF scientific scientific day 2025 has a wide range of topics we are going to discuss, mainly on workforce management, community engagement, quality of care, and so on. So my request to Mr. Rajendran is please share your key points with us of today's deliberations, so that we can include those things, whatever the key points you are sending to us in our national health policy and master plan, which we may have missed certain things. Okay. With that, thank you very much for inviting us. Thank you.
Thank you, Parthasarathy, Dr. Disanayaka, Dr. Arya Ratne, and Dr. Sridharan for setting the tone for today. I would now like to invite Professor Devi Vijay. Professor Devi Vijay is a professor at Indian Institute of Management, Calcutta. Her research explores inequality, institutions, and collective action in healthcare. Over 15 years, she has documented various aspects of community-based palliative care in Kerala, India. She's here to deliver her keynote, Frontiers of Abandonment, Frontiers of Care.
More. So somehow it feels like you're in a room with kindred spirits talking about an issue that concerns you. Thank you to the organizing committee that's been working back end for all the support in getting us here in the first place. I'm going to start with thinking about, the very idea of sans frontières, like without borders, in a world today that just seems to be in such a race to construct borders, right? I think Mr. Sarathy referred to the borders that we create with misinformation and disinformation. We're so quick to build these walls, ghettos, encampments, enclosures, prisons, ever-expanding imperial frontiers, right? We also want to enclose, privatize whatever commons we have left, and even incarcerate and imprison any form of thought itself. So what do frontiers mean in that context? I'd really like to begin with that, just to set the page of what is it that I'm thinking of when I'm thinking of a frontier. So I'm going to spend the rest of this talk first talking about a frontier of abandonment, where we worked at. Is it possible at all to think about possibly radical frontiers of care in today's world? And just very briefly at the end, think about, is it possible to think about knowledge without frontiers, knowledge without borders? To set the note, right? Like, what is it that we are thinking about with frontiers? Here I'm going to lean on the work of anthropologists, sociologists, and urban geographers who are thinking of frontiers as spaces of extraction, spaces of the contact zones that we have between wilderness and civilization, if you may. These are spaces of explicit annexation of land, of people, of resources, right? They've been integral to colonial capitalism, the way we've understood it. Think about the new discovery of the new world, the loot of wild frontiers, all under the assumption that we're on a civilizing mission, right? We will civilize these frontiers, tame them to live better lives. And this has been the experience of South America, the Caribbean, South Asia, Africa, the large majority of the world. In such expanding frontier zones, people who have lived off the commons lost not only their resources in terms of food, fuel, medicine, but they also were erased in terms of their forms of knowledge, their very aesthetics. So I'm going to quote from Raj Patel and Rupa Maurya here in their wonderful book, which is called Inflamed: Deep Medicine and the Anatomy of Injustice, where they talk about, the enclosure of what we consider commons, our forests, our ponds, etc. But also, in this process, how women, for example, lost the possibility of practicing the work of care and medicine that they would otherwise conventionally do. And these were essential sites of power and knowledge in particular forms of tribes and feudal societies. But this production of frontiers is not a pre-capitalist history, right? A prehistory that we're talking about. If we consider Gaza today, and the frontier of corporate profiteering that we are seeing in Gaza, even before you're thinking about the state of Israel and its imperial allies who have been focused on the annihilation and dispossession of peoples, we're also seeing the discourse of encampments, of future profits to be made, right, through luxurious resorts, and we know the script. So while the political and economic elite are quick to build their spaceships and artificial islands and glorified gated communities, the global majority have the debris that is left behind, right? So what do we do with these frontiers in this very wrecked planet in political, economic, and ecological ruination? So I'm going to talk about one particular site where we've been working on for a few years now, since 2018 at least. And walk with me through Basti. Basti is it's a pseudonym that we've applied. It could be any place in India, but this is particularly next to a landfill in Ahmedabad, which is next to the Pirana landfill. People from Ahmedabad would know Pirana. It has about 3 75 feet high garbage mountains that are spread across 84 acres. They contain approximately 12.7 billion tons of waste from the city and surrounding areas. This landfill, no surprise, has chemical and medical waste. It's toxin-ridden. Scientific reports, enough scientific reports have indicated this. We have the evidence that borewell waters in these areas have high levels of salt, magnesium, metals, chloride, anything that people should not be consuming in such high levels. This is just a Google Earth image of it. You'll see that is the landfill, and then you'll see this density, high density of population around this landfill. All of Ahmedabad does not look like this. This is the particular part of Ahmedabad which has been increasingly ghettoized and enclosed, particularly for Muslim communities. As one of our interlocutors here told us, when it rains, waste flows down the Kachra mountain, alleys clog up, houses are flooded, disease breaks out, stomach infections are there, there's typhoid. They are killing us with slow poison. Now, this is important to understand because this particular settlement where we studied, this is a resettlement colony of the 2002 pogrom. So this is not a planned state intervention, but this is rather an NGO which rehabilitated the people next to the landfill. Now, Nazim Bhai and his wife were actually victims of they were survivors of the 2002 pogrom, and as they said, majboor the, we had no choice but to move to this place if we wanted to ever construct a livelihood. Now, I do not need to break down for this audience the range of health conditions the residents here would face. They have chronic and terminal health conditions, breathlessness, kidney failures, alcoholism, substance abuse, respiratory, skin, I can go on. My friend and co-author on the paper that we worked on, Abrar, he tried to run to the best of his possibilities a charitably run, because there's no state intervention here, health clinic next to this landfill. And no surprises, it was very hard to run this because you wouldn't get qualified medical professionals who could work here for more than 4 to 5 months at a stretch. Now, people mobilize, they try to build sort of wall around this. There's no point of a wall because waste anyway seeps through the wall and infiltrates the water, contaminates the water. But, and we can all talk about this as a particular case, a story, if you may, of individual suffering, of the ghettoized poor, of climate refugees, of humanitarian needs, and so on. But I'd like to maybe shift the focus, shift the register here a little bit, and talk about the systemic forces, the more spatial and material forces that produce such zones and make them normal in our social fabric today. Specifically, I want to talk about the question of abandonment. Now, for me, abandonment can be considered in 2 ways. First, we think about abandonment of how people have just been abandoned. There are no public infrastructures here. There are no public schools. There are no public hospitals. There's no public water supply. At least in the period that we were working here, they kept mobilizing to get municipal water supply, but of course this was considered an, quote, illegal encroachment, and so on. So this is the one form of abandonment. But the other side of this abandonment, and if I were to kind of look at the word abandon a little differently, is the free circulation of capital in this region, right? So it's not just small forms of private capital, but also very big forms of corporate capital. If you're thinking about e-waste recycling, where does this go, right? So we often tend to think about these encampments as sites where people are cast away. But there's also the other side of it where people are tied back into these global flows of capital to do all the dirty work that cannot be done anywhere else. So we create disposable populations that are then tied back into forms of work that nobody else will do because they're so toxic. So we had people who were working in oil reprocessing units, aluminium resmelting units, and and waste recycling of all kinds from the landfill, but also from the entire city of Ahmedabad. So what I would like to underscore here is that larger theater of war, if you may, on global populations, right? Which is this global precarious labor force which gets conscripted into these imperial forms of wealth accumulation, the wars, the policies that are implemented by state and international financial institutions like the World Bank and the IMF. This larger theater of war that our political and economic systems create that abandons large swathes of the population, particularly in the global south, as disposable populations. But even as they are abandoned, they serve, the bodies are serving as toxic sinks, as relay points in this capital flows. And I'm going to quote from Vinay Gidwani here when he says that those inhabiting these worlds are actually providing a daily gift to the rest of the world when they're internalizing this toxicity in doing the work that they do in this really unlivable world that we've created. And there's so many such frontiers. Of course, this frontier is along the vector of religion, but you can look at similar frontiers that have been created along vectors of caste, tribe, ethnic identity, and so on. So many frontiers that we create in this world. So where do we go from here? And is it possible, if at all, to retrieve care in any way? In one of our conversations that we were having before the conference, There's so many forms in which people are talking about care. Uber cares for you, Ola cares for you, Amazon cares for you. There's digital well-being programs that are being conducted. Even BP and Shell cares for lands. So where do we go? Is there a possibly more radical form of care that we can think about? Here I turn to the people of Kerala for an answer. This is some of the work that we've been doing since 2009, actually, one of my earliest engagements from my dissertation days and then thereafter, entanglements that are people who are volunteering here with community palliative care, people who have possibly more ground experience than me. But I'm going to tell you why this movement is so fascinating. I'm sorry about the small font, but I'll really try and capture why is it that Kerala becomes so interesting as a format of care. For those of us who are, many of you may be already familiar with Kerala's community-based palliative care movement, but just to give a quick snapshot, this was something that started in early 1990s in the Government Medical College in Kozhikode with a group of doctors. And they were really thinking that, well, there's terminal pain and it's not being addressed, so how do we respond to this? Now, where this account gets really fascinating is when the community comes in and you have volunteers who are supporting the very understaffed pain clinic that the doctors are running. And when the community comes in the 1990s, between 1993 and 1998, they're coming in and they're really lending their voice to this notion of what is pain and what should palliative care be. And they said it shouldn't be about just terminally ill cancer patients. It should be about all kinds of people with conditions that are, for example, cardiovascular conditions, chronic cardiovascular conditions, bedridden patients, chronic respiratory conditions. Why should we not? They're also suffering. So when, as one of our volunteers told us, where doctors see symptoms, the community sees suffering. And so this is how we respond. And the way they looked at suffering was not just the biomedical form of suffering. They looked at suffering as financial, as emotional, as psychological. They looked at all of these different forms of suffering and said, we'll respond to all of this in the community. And that really changed the landscape of this movement. It redefined the nature of care. What is it? It's not just the medicines, but we're going to provide financial support, children dropping out of school, we'll put them back in school, we'll give food kits. There's a whole range of care. But it also changed the number of organizations that came into the play when community came in. So rather than being restricted to hospitals where the doctors were working, care moved to the communities. And suddenly, by early 2000s, you had hundreds of community organizations looking for chronically and terminally ill people across Kerala. You can see people here trying to mobilize food for the house of somebody where they see that there's no food that's been cooked during a very routine home care visit that's going on. And what was fascinating about this whole exercise was today, if you look at India, the whole of India, there's about 3 to 4% coverage in terms of palliative care. But in Kerala, all 14 districts receive palliative care, or there are about 400 plus community organizations, and I'm sure this number will change by the end of today, because the number of organizations keep changing, and there are over 900, all the panchayats. So eventually the community is mobilized and said, we're not becoming a parallel institution, we want the state to step in, and the state has to take up its responsibility. So in 2008, there was a palliative care policy, which said that all primary health centers will provide palliative care, and all the district hospitals will now provide palliative care as well, eventually, with various revisions of the policy. So what we see is really a bottom-up care infrastructure being constructed by communities and demanding better state accountability for the same. Of course, this has resulted in various forms of societal consequences. We can see that during particular epidemics, the pandemic, but also floods, communities have then become a mobilizing structure, an available mobilizing structure for all of these emergencies that otherwise have been we're familiar with in the last decade. So what is fascinating here, and I just want to conclude in the last a few minutes about this, in particular about Kerala, which is we're talking about, when we talk about frontiers of care beyond terminally ill, as I mentioned, cancer patients to a range of conditions, changing the frontier of care from the hospital to communities and homes, the nature of care to total care. So you had free home-based care, which is provided in communities to people. And of course, there are a lot of constant questions about who is being excluded, which communities are not receiving care, what is quality of care. But there's a whole different level of discourse within the community, within the state of Kerala as compared to other states, just with this involvement. And to tie back to the question that I had about what does this tell us in terms of the crisis of care, if you may, that we confront across the world, for me, this is a Global South response. It is not an attempt to take a benchmark or a protocol that has been laid out in the Global North and kind of impose it on the Global South. This was a really Global Southern response to what communities need. Communities feel as something that they should be doing and translating the idea of care to something that is meaningful there. It's important, when I started this work, I never thought I'll have to talk about this, but my field teams, for example, would have typically, and most usually, a Muslim, a Christian, and a Hindu volunteer, and we work very comfortably along. But in today's India, with the kind of polarization that we see, I feel like it's important to talk about how communities, not just around different religious identities, but also political affiliations. Some people are in it because they're, communist, Marxist, or they're in it because they want to win a local election. But with all of these differences, people are able to come together and provide care for the patient. This is recognition, and it's forming a new form of commons, if you may. So this is the last part that I just want to talk to you about. So what do we do with all this that we know? That with the question of care, on one hand that I mentioned is the dominant global North-centric political, economic, and moral architectures that we live with in the world that we inhabit, that we've created a kind of generalized state of disposability across the world. And how may we retrieve care, if at all, from this very corporatized, depoliticized format today that our Uber and Ola are willing to sell to us, and construct care as a more radical act? How can we, if at all, reclaim care commons that are built along these solidarities that are across differences, as I just mentioned? Is it possible to think about internationalism in a world today so fraught with conflict and war? What do we mean by without borders? People on the ground, on the front lines, however, are constantly responding through mutual aid, through solidarities. There's a flourishing of care cooperatives, commons, community economies. And we've recently done a study of about 300 such studies across the world documenting. They're not all in healthcare. They're about alternative food cooperatives. They're about worker cooperatives as well. But just the idea that people are coming together for an alternative. But are we listening and are we learning to co-create health? So my submission here is, of course, and to build on what my colleagues before talked about, that we can't be in this, to quote from Mr. Sarthi, which is the sterile labs where we conduct our research. We need these knowledge without frontiers, right? Which is necessary to perhaps rebuild, repair, and reproduce a more livable, shared planet, if at all. The two ways we've been, there's this classic old, of course, folk poem, which many of you may be familiar with, which says, the law locks up the man or woman who steals the goose from off the common, but leaves the greater villain loose who steals the common from the goose. And this perhaps ties with some of the conversations I've also been hearing about, how people don't have access to the research that they publish. It stands behind paywalls. It stands behind global North journals that are difficult to publish in from the global South, and so on. The two quick experiments that I want to talk about, we've been working on. One is the peer community and organization studies. This is really the brainchild of my friend Eloise Berkowitz in terms of PCI and org studies, organization studies, but it's part of a larger network of peer community started in fact by scientists in France who are fed up with the corporate publishing structures. So this is open access, peer-reviewed journals, open access preprints right? Peer-reviewed preprints that we put out. And this is free, so you can submit and you can access this, you can access the reviews, the editorial comments, and so on. The idea of creating these kind of knowledge commons is that if knowledge is limitless, why at all do we enclose it? Why do we create these forms of artificial scarcity through journals, right? The kind of paywall journals that we're familiar with. And the second, of course, is more of an experiment with creating, and that's the image of Sabra that we have up here, which is really been our response to the sterility of the lab, where we're trying to bring, and inspired in many ways by the work that forensic architecture, for example, is doing, that we bring together art and the sciences. We bring together, if you may, art and the lab and the studio, as the forensic architecture folks talk about it. So how can we perhaps be epistemically irreverent and maybe a little more indisciplined with disciplines that are constantly excluding us, not representing us, and so on. So, Asra Taylor and Naomi Klein talk about how, in end-time fascism, you need a more open-hearted, unruly movement in the earth, right? And for us, how do we build this open-hearted, unruly movement? Can we start perhaps with dismantling some of these borders of our knowledge, embracing and reclaiming the beauty and abundance that exists in these knowledge commons with communities? So I'm going to stop there, and thank you so much for this space.
Yeah, I'm going to wait for her to turn around because I want to thank her. No, thank you, Professor Devi, for this insightful and heart-wrenching keynote. Disposable populations, you said. It frames today's discussion, highlighting the impact of neglect and abandonment, while also emphasizing the resilience of frontline workers, communities, and grassroots movements, shedding light on how communities are creating their own solutions without borders, particularly in times of crisis, and how we can engage and co-create, freely share knowledge, as she said, open-hearted movements to ensure safety and quality of care moving forward. It is time for a tea break. Before that, I have the Wi-Fi password for those of you who want it. The name of the Wi-Fi here is Galadari Wi-Fi. And the password is, are you ready to note down? Okay. Number 2, T for Tata, X for xylophone, G for Gaza, the number 8, Z for zebra, the number 57. I'll repeat it once more. Number 2, T for Tata, X for xylophone, G for Gaza, number 8, zebra, number 57. We'll resume promptly at 10:30 a.m. with session 1. Please don't forget to explore the innovation kiosk and the exhibits, as well as the posters on digital display in the foyer. See you. Okay, 10:45. See you.
මේක ඇවිල්ලා ගියද layer 4 නේ. දෙන්න මේ mic එකද?
Test 1 2.
Okay. Test?
Test one.
Hi, everybody. Could you please come back to the room? I think we need to. Okay. Hi, everyone. Could you please take your seats? You can bring your coffee and sandwiches inside. All those outside in the foyer, could you please come inside with your coffees and sandwiches? Okay. All right, we are starting now. We are starting with the session 1. The theme of the session is Empowering the Unsung Champions of Care. In this session, we'll explore the vital contributions of those who often go unrecognized in healthcare services, with presentations that highlight innovative approaches to supporting frontline care and caregivers. We'll begin with an exhibition spotlight, a 5-minute exhibition spotlight about frontline care during civic movements in Sri Lanka. This is themed Sanity Amidst Chaos, the curious case of the Aragalya street medics by Dr. Vinya Arya Ratne, director of Sarvodhya Shramadana movement of Sri Lanka, and Udesh Fernando, Uppsala University, Sweden. Additionally, this session will be chaired by Dr. Vinya. Dr. Vinya, if you could please take a seat on the stage. Dr. Vinya is the president of the Sarvodhya Shramadana movement and a senior community physician. He has extensive experience in public health, community development, disaster management, and supporting war-affected and internally displaced communities. He serves as the co-chair of the United Nations Humanitarian Country Team and has been a leading force in humanitarian efforts in Sri Lanka. Please give a warm welcome to Dr. Vinya. I would also like to invite the presenters on stage. Dr. Madhava Dharmadasa, Ministry of Health, Sri Lanka. This is correct, yeah? Yeah. Dr. Nidhi Tripathi, Sri Chitra Tirunal Institute of Medical Science and Technology, Uttarakhand, India. Dr. A. Rehman Mulik, Bangladesh Medical University, Dhaka, Bangladesh. And Dr. Arsha Kochu Vilai from Sri Chitra Tirunal Institute of Medical Sciences and Technology will be joining us online. I was told again to announce the exhibit, so I will let Dr. Vinya you talk about the exhibit. Yeah.
Thank you, Simrin. Good morning again. We all who are in the health sector working as healthcare providers face different experiences during our lifetime. When I started my own career as an intern medical officer 30 years ago in the district of Polonnaruwa, I had to face experiences that no other probably doctors of the previous generation had to face. The war. Since then, we have faced tremendous challenges in Sri Lanka as health sector and also as medical practitioners. To name a few, tsunami, COVID-19, and then of course, Aragalaya, which I am going to present to you the story of what we call street medics. And I am joined by Mr. Udesh Fernando. I think he's online. He's now a PhD candidate at the Uppsala University. So it was a new experience for us because we were also wanting a change in this country, particularly at a time when people were suffering, and we are as development practitioners, medical practitioners, we were experiencing firsthand the impact of the economic crisis. And then this non-violent change that was unfolding in our country, as medical professionals we needed to also intervene, and this is the story. The story is titled Sanity Among Chaos, the curious case of Aragalaya street medics. And I invite you to watch this video.
In early 2022, Sri Lanka was a nation on the brink. An unprecedented economic crisis plunged the country into chaos, sparking a powerful people's movement known as the Aragalaya, the struggle. As hundreds of thousands took to the streets, a different kind of front line was being drawn. Amidst the turmoil, a group of doctors and social workers anticipated the inevitable: casualties. What began as a call on social media quickly amassed over 300 professionals. They were the street medics. Initially armed with just backpacks of first aid essentials, moving silently through the crowds. As the protests converged at Goal Face Green, their mission evolved. In collaboration with organizations like the Sarvodaya Movement, Sri Lankan Red Cross, and St. John's Ambulance, a simple first aid station grew into a fully fledged field medical unit. They provided everything from emergency care to dental services and psychological first aid for the resident protesters. But on May 9th, their neutrality and humanity were brutally tested. The day that became known as Black Monday. Government supporters stormed the site, unleashing violence on unarmed civilians. Over 130 people were injured, some with severe head trauma. The medical teams, having already prepared an evacuation plan, managed to get their staff to safety, though the trauma of the attack lingered. The attack did not break them. It solidified their resolve. In the volatile weeks that followed, they expanded, creating communication lines with major hospitals and equipping mobile teams with gas masks. On July 9th, as the protests reached their zenith, the medics activated their full emergency protocol, treating nearly 300 casualties in a single day. Over 3 months, this incredible collective of volunteers treated more than 3,000 patients and coordinated 450 critical hospital transfers. Guided by principles of impartiality and humanity, they provided sanity amidst chaos. The Aragalaya street medics became a powerful testament to professionalism and courage, offering a global benchmark for how to provide care in a nation's most trying hour.
So we start this session, which is titled Empowering the Unsung Champions of Care, the Way Forward in Health Workforce Management. We are used to structured provision of healthcare, but not to this type of situations. Even if we are trained to respond to emergencies, we are not trained to provide that service in the streets in a very unpredictable condition. Therefore, today we have four presenters who are working in different conditions in different parts of the country and in the region. So I would like to first invite Dr. Madhava Dharmasena. By the way, we have 10 minutes for each presenter, and then we will, after all four presentations only, we will have questions and answer session. So Dr. Madhava Dharmadasa is a medical administrator at the Ministry of Health in Sri Lanka with over a decade of experience in public health and hospital management. He holds a master's degree in medical administration and is currently pursuing his MD in the same field. Dr. Dharmadasa has held leadership positions in tertiary care hospitals and has actively contributed to national health programs including COVID-19 prevention and family planning. His areas of interest include patient safety, clinical guidance, health informatics, infodemic management, and the governance of artificial intelligence in healthcare. He has authored several publications on patient-centered care, patient safety, and healthcare quality improvement. Over to you, Dr. Dharmadasa, to make your presentation.
Thank you very much, sir. So, good morning, respected Chair, Dr. Vinya Ariyaratne, members from MSF, dear friends from across Asia and beyond, ladies and gentlemen. It is both an honor and a privilege to stand before you at this prestigious forum. Today I will share with you a health sector innovation that was born in a rural hospital in Sri Lanka but carries lessons that may resonate far beyond. So my topic is low-cost psychosocial support system to improve healthcare workforce well-being in a post-crisis rural hospital setting in Sri Lanka. Let me give an introduction to the hospital first. Base Hospital Kantale is a government hospital in Trincomalee district, serving a predominantly rural agrarian population. And it has a catchment population around 1 lakh. Total workforce is 450 staff and bed capacity 235. Annual admission is around 17,423 and bed turnover rate is 68.42. So first of all, I would like to give a brief introduction about what happened and the sequence of events. In 2022, when I was appointed as a medical superintendent after completing my MSc in medical administration, the hospital was just emerging from two shocks. First, COVID-19 pandemic, during which Kantale functioned as a designated treatment center. Second, Sri Lanka's economic crisis, the worst in our history. While services are normalizing, it became clear that our health staff were not the same. Burnout, interpersonal conflicts, and low morale were common. Staff were facing the double burden of pandemic fatigue and economic crisis. So let me highlight two serious incidents underscore the need for a focused mental wellness program for our staff. In one case, just before my appointment to the hospital, a female staff member tragically lost her life in domestic incident just outside the hospital gates. And this deeply affected the morale of our team. And just weeks after my arrival, we encountered another serious family conflict involving one of our healthcare workers, but fortunately with the intervention of our psychiatric consultant, we were able to resolve this case peacefully. But it served as a reminder of hidden challenges faced by our team members. So as we explored ways to support our staff, it became clear that conventional counseling programs would not fully address their needs. We did have formal psychiatric counseling, but attendance was very poor. Why? Because in a small rural community where everyone knows everyone, staff fear stigma, breaches of confidentiality, and gossip. So recognizing these barriers, we needed an innovative and discreet approach to support the mental wellness of our staff. So this is our objective, to promote the mental well-being of healthcare staff by implementing structured forums and expert-led discussion aimed at reducing stress and burnout, thereby fostering supportive and resilient work environment. So we call it a friendly atmosphere. So how it began? So we asked ourselves, how do we create a safe, stigma-free space for staff to open up? That was the turning point. The core of our project and the innovation, I would say, was not high-tech, but human-centered and context-sensitive. The goal of Sahudra Danav was to provide an anonymous platform for staff to share their concern in a safe, judgment-free space. We established 3 secure boxes in discrete locations within the hospital, away from public view, to encourage staff to submit their concerns anonymously. This approach aimed to build a culture where individuals could express their struggles without fear of repercussion or breach of confidentiality. We communicate the purpose and the structure of Sahudra program through management meetings, posters and social media, and designated the 22nd of each month as the day to collect the submission. These submissions were then reviewed by expert team led by our psychiatric consultant. Then monthly forums were held on last Thursday of every month, and issues raised were reviewed. Discussions topics were chosen directly from the staff concerns. A psychiatrist or expert was invited to facilitate. All category staffs, nurses, support staff, technicians, and doctors were welcome. At first, only a single paper appeared, but gradually, as trust grew, the boxes began to fill. Out of this simple beginning, our program was born, and it was later named by a staff member, Sahudra Danav, meaning a friendly atmosphere, a place where friends help each other. Program was simple, low cost, but relevant to the realities of a rural hospital workforce. So what are the topics we discussed? Burnout, stress management, conflict resolution, morbid jealousy, substance misuse, how to handle conflicts with mother-in-law. It's very common in our part of country and our part of Asia. How to handle relationship issues, marital problems and lead a happy life, work-life balance, work as a team, management of poor anger control, mental health issues among teenagers, how to balance income and expenditure. So, ladies and gentlemen, well-being is not built only through lectures or discussions. It also blossoms when people laugh together, sing together, and celebrate together. All these activities came from the submission from our staff members. That's why we extended our Sahudra Danav beyond the meeting room into the heart of our hospital culture. We organize musical shows and talent evenings where nurses, doctors, all the staff members share their hidden gifts on stage. I have shared some photographs. I couldn't share all the photographs because of the limited space. And we received spirit teamwork through sports events, reminding ourselves that playing together builds stronger than working alone, and it was the beginning of a new year also. And I want to remind you all that there was a big economic crisis at that time. So we reached to our staff families. We provided school books and stationery perks for the children, for the staff who needed economic assistance. And then we even extended our hand to the community, donating sports equipment and also books and stationery packs to the nearby school. These activities create something powerful, not just a support program, but family spirit within the hospital. What began an anonymous suggestion boxes grew into a culture, trust, joy, and mutual care. Then further improvements on the way from our secure boxes. We introduced the online submissions. They can scan the QR code without their email, the email addresses. They can submit their concerns. And during the monthly forums, if someone needed the support more than like individual support, we share the numbers so they can discreetly call that person, especially our psychiatrist. He had a hotline number, so they can call to him and get a personalized care if they need it. And ladies and gentlemen, what we did achieve through this simple low-cost program. First, the numbers spoke. Over time, participation in the monthly forum steadily grew. Feedback forms revealed that staff felt more supported and better equipped to manage stress. Importantly, we saw clear reduction in reported burnout cases and interpersonal conflicts within the hospital. But beyond the numbers, change were visible. Staff who once avoided counseling began volunteering to share their challenge in open forums. Conversations that once happened in whispers or not at all were now brought forward in the safe and constructive ways. So these are the feedbacks. We got it from the suggestion boxes, and there's from the two languages, Sinhala and Tamil. And then there was another powerful outcome, I must say. Enhanced staff morale translated into improved service delivery. First, I would like to share this one. This January 2023, we were able to open the dialysis unit. I want to emphasize a little bit about this dialysis unit because at that time we had a very crisis. I mean, staff shortage. To give an example, we need 72 doctors in Kantale Hospital, but we had only 28 at that time. And we opened this dialysis unit, which was actually the equipment was given to the hospital 7 years back, but we couldn't start a dialysis unit. But we were able to start this dialysis unit, and also there were a lot of patients. I mean, before opening that, the patient has to travel more than 80 kilometers per day to get the dialysis. And you know, dialysis is a continuous process. So most of these families are daily wages, depend on the daily wages. They are not traveling. So today, I'm proud to say now we have 46 patients have been dialysis, and now they are going to expand. Now we have 3 machines, I heard. Now they are going to expand another machine. So they are expanding the dialysis unit. So these are the indirect results from this program. And also we launched the NCD clinic, which was not there at that time. And also we organized iCamp also during this period. We did 100 cataract surgeries for our patient. These are the photographs of this thing. So challenges definitely we faced. Initially misunderstanding of the program. Many staff members initially perceived these suggestion boxes were formal complaint mechanism, then low initial participation, and then we have to address diverse concerns. So careful moderation and prioritization was needed to avoid participant exhaustion. Why is Sahudra Danawa is innovation? Because It's proactive, addressing mental health before crisis erupt. Low cost, using only existing resources. Replicable, any institution, anywhere we can adapt it. Sustainable, proven to survive any leadership changes. Empowering, giving frontline staff voice and dignity. In the words of our staff, Sahudana is where friends meet each other and help each other. And the sustainability, I will say, because it continues with the consecutive medical superintendent, Dr. Paul Roshan, and Dr. Vasul Ratnavira, so it was sustainable. And conclusion, Sahudana has been effective and sustainable initiative for improving mental health among healthcare staff of Base Hospital, Kantale. So these are my recommendations because it can be a replicable model. An acknowledgement, Dr. Asita Basita, consultant psychiatrist, and subsequent medical superintendent, Dr. Paul Roshan, Dr. Vasul Ratnavira, Dr. Pumidra Singh, and all staff members of Base Hospital, Kantale. Ladies and gentlemen, what we learn at Base Hospital, Kantale is this. You do not always need millions of dollars, complex systems, or high technology to protect the mental health of your workforce. Sometimes, all you need is a small wooden box, a safe space to speak, and the courage to truly listen. As we face global challenges in health workforce management, may we remember that sometimes the most powerful innovations are not expensive technologies, but simple human-centered systems that give our caregivers the care they deserve. Thank you very much.
Thank you. Thank you very much, Madhav, for that excellent presentation. We have Dr. Nidhi Tripathi, who will present on the theme Exploring Gendered Challenges and Vulnerabilities, a qualitative study of ASHA workers in Uttarakhand. Dr. Tripathi is a dentist by training from Rishikesh and has completed a Master of Public Health from SCTIMST in Trivandrum. She was born and raised in the hills of Nainital, Uttarakhand, and she has witnessed how geography shapes lives, often making access to basic health services a daily struggle. After years of working as a clinician, she felt driven to explore deeper systemic issues, not just working within the four walls, but working within the system and alongside the community. Her current work is inspired by the strength of women frontline workers, ASHA. In the remote Himalayan region, the struggles are unheard and ignored, yet powerful, that keep the health system standing, and these voices need to be heard. Over to you, Nidhi.
Thank you so much, sir. So, good morning, everyone. Today, I would like to take you on a journey of 16 ASHA workers, which I interviewed for this study. So, I will be the voice of these women. I will be presenting my work as Invisible Labor, Visible Struggles, the Gendered Vulnerabilities of ASHA Workers in Uttarakhand. So firstly, I would like to introduce who are ASHA workers for those of you who don't know. ASHA is basically an acronym for Accredited Social Health Activist. These are the women who are not salaried, but they are incentive voluntary-based workers who need to perform certain tasks and responsibilities in their own community, elected by their own community, so that they can serve the vulnerable population and help them in mobilizing to get the access to the services. They are supposed to work for 1,000 population in their own community, but the 1,000 population won't be a specific village, it can be a scattered population. They are known as the backbone of the health system because they are the important face of the public health care and the systems for the community, because they are working for the vulnerable population who don't have direct access to these healthcare services. So they are kind of bridging the public health system and the community and providing the services. It all started from a program, Humanitarian program, which held in 2000 in Chhattisgarh, where the Humanitarians are known as the friends of the community, who did the same kind of work, and after a huge success, the NRHM, National Health Rural Mission, envisioned this program in Pan-India. So they are respected globally, but at a domestic level, they are not being recognized for their struggles and their work. what motivated me to do this study? So this is something very personal. Like I was introduced to a house help in my home. So she was an ASHA worker. She had to do all the house chores and also perform the ASHA work related activities. So I have seen her struggling with the responsibilities at the community level and at the household level. So I thought of understanding this from an aspect of gendered context and understanding what can be the external factors, basically the difficult environment where they need to perform their work and how it shapes their life. And also it was highlighted during the pandemic that the ASHA workers were struggling for the recognition for basic payments, and there were no safety security nets for them. So the study area was one of the district in Uttarakhand. Uttarakhand is one of the northern state at the laps of the Himalayas. So it has difficult terrain as well as forested areas, which makes the work of these women workers much difficult. And also along with that, the state has also proneness to the environmental hazards like flash floods, cloudbursts, and the landslides. So one of those districts was chosen accordingly, and the rural settlements are also there. Methodology, I interviewed 16 ASHA workers, and along with that, what I did was I asked these ASHA workers to click some of the photographs. So it is a photo voice, a photo narrative technique where these women were asked to click photos which they feel these are the challenges to do their work. And it can be anything. It can be an environmental thing, it can be a feeling, it can be anything which they feel it is challenging for them. And I did the analysis, and after the analysis, I could come up with a schematic diagram where I could identify certain risk factors and how it can be affecting the life of these ASHA workers. So some of the findings I would like to highlight here, the environmental challenges. Here the environmental challenges, I am not just talking about the geographical, but also I am talking about the environmental, which can be an institution level. So these are the photos which are shared by the ASHA workers. The first picture shows the steep terrain, the forested areas. So think like you are a woman who is getting a call 2 a.m. late night, who is supposed to go for the institutional delivery to help a beneficiary. They are not given any kind of safety, just holding a torch, going through these difficult areas and terrain, and need to provide the services. So one kind of challenges they are facing it here. Firstly, they need to seek permission from their family members. Then another challenges are there, like when they are taking the women for the institutional delivery, they need to convince the families also. After that, the challenge is not ending it here. They are also facing challenges related to not getting a commute to go to the higher centers. So they need to provide the services from their own, like they need to hire a cab, they need to spend their own money. And after that, when they are reaching to the hospitals, there is non-availability of the staff, equipments, and further they are referred. In all this, they are being blamed by their own community member because they are the face. They are the one who are convincing these women to go for the higher services and the care. So also there is a fear of animals, humans, and there are also risk of being attacked. They are traveling with strangers. There is not just the fear of getting into some accident, but also there is fear of getting harassed or abused. Coming to the gender challenges. Now, all these risk factors were already there, now we are adding to it a gender. So, patriarchal norm is very much highlighted in my state, so there is restriction for the women's mobility. Like women are not appreciated much moving out of their house late night. They need to seek permission. For that, they are being blamed, we are put up into scrutiny within the community, and also they are given moral policing for work they do. Their work is not considered a respected women's work, but it is rather seen as a shameful work. Along with that, there are taboos, like family planning is not to be talked by a women at a community level. And these community are not just the people or the strangers, they are the elders who are in a way related to these ASHA workers. And also there is stigma within the community regarding the menstruation. Like during menstruation, women are not respected to be coming to the families of the people or in the community, because they think it is sin to be coming inside the house, and there will be sin, and the deities should not be touched by these women. And along with that, there is criticism and judgment, because ASHA workers had to perform their household chores as well as they need to look after the community. So they need to sacrifice some of their personal engagements like the festivals and the gatherings. And they are also questioned being as an idle woman or a mother. So one of the ASHA workers shared that, I am often questioned and said by my own family, you have not done anything praiseworthy so that you are so proud of it. Along with that, there is labor inequality. There is invisible labor. These are the women who are working tirelessly for the community, and after that they are also doing the household chores. They need to take care of their own family. They need to work for their family, the elders, and make money, but they are not being respected. So the photo at the right hand side is a screenshot from a video where the two women were working. One of them is ASHA worker. So she said in a very candid mode that men are asking, like in my family, when I come from community visit, my husband asked me to do household chores. Like I am not even offered a glass of water. So men need not to cook food and perform household chores. Along with that, there is devaluation. They are not being respected at their household level. So how it can be expected at the community? Closing reflections will be, it is raising few questions like why women's work is normalized, why it is more shaped by gender, not seen as an skilled workers, because these are the women who are there for these beneficiaries to help them with all kind of difficulties. They are the vital pillars, no doubt, but they are in the cycle of exploitation and duty. Their work is reduced just to the extension of domestic role. There is care, there is sacrifice, and there is silence. And the silence is here, the struggles they are facing in day-to-day life. It is a patriarchal continuum of invisibilizing women's labor and undervaluing their contribution to public health. As ASHA workers said, we ASHAs are seen as slippers. We can be used for time being, and when the purpose is fulfilled, we are thrown away. What can be done? Firstly, we need to sensitize the community as well as the system as per the gender. We need to provide them social security benefits, and there should be transparency for the payments. We need to understand that ASHA worker who is working at a plains area where there is good accessibility for the commute for the hospitals will be the same for the ASHA worker who is working at a very remote location at a hilly area. We also need to provide them gender-sensitive infrastructure and safety measures. As it came through my study that ASHA workers are not provided any kind of safe space at the hospitals when they are going with the beneficiaries to the hospitals, and if there is a pregnant woman, they need to be at the hospital for 3 to 4 days. So they are not provided any kind of safe spaces where they can take rest, they can have food. So they have to manage all those things on their own. And the money at the end is just 3,000 or somewhere to 5,000, depending upon the states. I would like to acknowledge 16 ASHA workers who opened up with me and shared their stories, and through this I am able to present my work in front of you all. I would also like to thank NHM office, the professors and family and friends. Thank you.
Thank you, Nidhi, for that excellent presentation. I would now like to invite Dr. Asha Kochuvilayil from the Sri Chitra Tirunal Institute for Medical Sciences and Technology is joining online, and I hope is there. I hope she's there. Okay, can see you. Okay. Dr. Arisha Kochuvilayil is a dentist by training who discovered her passion for public health through a strong commitment to community well-being. Her work focuses on elderly and long-term care systems with a particular emphasis on the challenges faced by informal caregivers. She is currently pursuing a PhD in public health and has published widely in reputed national and international journals, contributing valuable insights to the fields of aging, caregiving, and health systems research. And Dr. Asha's presentation is on mental health interventions for caregivers of children with neurodevelopmental disorders, a holistic approach in Bangladesh. Over to you, Asha.
Hi everyone, am I audible?
Yes.
Okay, thank you so much. I think there was a small correction for my presentation title, that is, I'm presenting my study titled From Burden to Well-being through the Capability Approach, Identifying Capabilities for the Mental Health Well-being of Long-Term Carers, which was supervised by my professor, Dr. Ravi Prasad Dhamma, Professor Sri Chittathirunal Institute of Medical Science and Technology, Kerala, India. An institute of national importance that work at an intersection of clinical care, medical research, and public health. Next slide, please. Okay. Kerala, we are going through a demographic transition with rapidly increasing aging population, which in turn increases the dependency and need for long-term care. Like all other middle and lower income countries, this care is provided by the families, being the invisible backbone of this long-term care. They bear this, shoulder this immense responsibility, but often their mental health needs are neglected. Even in Kerala, like Dr. Devi Vijay mentioned in her keynote presentation, has a fascinating palliative care model running for last 20 years. But there is no formal support system available for these family caregivers. Here I would like to pose my question, that is, what these carers need to maintain their mental health well-being while they provide care. With that, I am coming to my aim. My aim is so simple but critical: to identify the critical capabilities needed by family carers in Kerala to maintain their mental health while providing long-term care. Next slide, please. For this, I used a qualitative design approach using the capability approach framework. That is, capabilities is nothing but what are the actual freedoms or opportunities needed by these family carers to maintain their mental health while providing their care. For this, I used the Robbins steps for listing the capabilities. It begins. Okay, thank you. It begins with a brainstorming exercise where through the local experience and context-based insight, we listed the initial list of capabilities. Adding to the list is the, can you go back to the previous slide? Okay. Adding to the list, we did a scoping review of health-related literatures. Try to see what are the capabilities really meaningful for these carers and what the health-related literatures talk about these capabilities in the mental health and caregiving context. This leads to an initial list with when I compared the list with the Sense and Nussbaum's capability approach to bridge the practical list with the theory. Next slide, please. Then this undergone an expert discussion where for its conceptual rigor and relevance, for each subsequent step, there was a further iteration, addition, and modifications of capability happened. This is followed by phase validation with peers, where I try to see what is the applicability and appropriateness of these lists that I developed. Then I went to the carers to see what are their real life experience, what are the capabilities they are exercising, what are the capabilities they are not able to exercise through in-depth interviews with them. The inclusion criteria was carers providing care for serious health-related conditions that require long-term care for more than 3 months, and the ethics clearance were obtained from Sri Chitra. For analysis, I myself did the translation and transcription, ensuring the contextual relevance, and an inductive coding approach was done, and the coding process and the anonymized transcript were independently reviewed by the auditors. Next slide. Coming to the result, the 4 personal capabilities consistently emerged as important. That is, being able to exercise agency and autonomy, being able to live a productive life outside of caregiving, being able to uphold their dignity, not merely reduced, having a time and space to rest or recover. Next slide. I feel like I am tired of, I cannot go out, I cannot do anything. A 33-year-old woman caring for her mother-in-law with cancer told me this. This is not just about she is not able to work. It is about how she is not able to make decisions for herself, how she is not able to find purpose outside of her caregiving, how she is not able to maintain her dignity and having a space to rest. Next slide. And another set of 6 relational and social capabilities also emerge. Being able to emotionally aware of one's own emotions and the care recipient emotions, being able to access, use and control resources for their caregiving, being able to communicate one's concerns and listen to others with respect and dignity, being able to establish interpersonal relationships outside of caregiving, being able to actively participate in society so that a sense of community belonging there, being able to have support systems for their caregiving activities. Next one. I get 10 diapers per month only for night use. During the day, I wash, clean, change him again and again. I'm too weak to do everything. 64-year-old woman caring for husband with dementia told me this. This is not just a limited access to essential resources. It is also how each of these capabilities being stretched. It is about how invisible her caregiving was. So when these capabilities being stretched, their mental health is eroding. Next slide. This study is not free from limitations. The empirical constraint is that the application level, the feasibility, the measurability related issues and the policy potential related to this list I generated. For this, currently I am conducting a large-scale cross-sectional study across the state to overcome these limitations. And the language of capability is theoretically driven and using it in a simpler sense to understand the policy because is often a challenge. Next slide. To conclude, these mental health capability indicators can be incorporated into routine program management and assessment to see how well the existing programs are addressing the needs of carers, how we can further improve these programs to meet their needs. Also can generate context-specific carer-centered interventions enhancing the mental health well-being. And these indicators can even be used for monitoring the mental health of these carers. Next slide, please. By focusing, I would like to say this as key message, by focusing not only the outcomes of burden or burnout without enabling the capabilities they need that risk failures. Moving from burden to well-being requires strengthening carers' capability for their mental health needs so they can thrive while providing care. Next slide. So this study, I would like to acknowledge all the carers who talked with me, shared their stories with me, also my field facilitators as well as Sri Chitra's academic and research team. Next slide. Thank you so much for this opportunity. I was not able to attend on offline. Thank you.
Thank you, Arsha. I think you saved time also with that excellent presentation. I made a mistake on the title. Actually, the title that I read was for the next presentation by Dr. Rahman Mulik from the Bangladesh Medical University, Dhaka, Bangladesh. I'll in a minute read his profile. But before that, may I request the participants joining online, if you have questions, please start sending them, because after Dr. Rahman's presentation, we'll be having the Q&A session. So Dr. Rahman will be speaking on the subject, mental health interventions for caregivers of children with neurodevelopmental disorders, a holistic approach in Bangladesh. Dr. Rahman is an accomplished public health professional specializing in occupational and environmental health. He holds an MBBS from SUST and MPH from NIPSOM and is a fellow of the Royal Society for Public Health, London. Dr. Rahman has extensive experience in research, program implementation and data analysis, contributing to projects funded by WHO, UNICEF and other international organizations. He has authored numerous peer-reviewed publications and presented at global conferences. He is known for his leadership, collaboration and analytical skills, and he is dedicated to advancing public health through evidence-based interventions and multidisciplinary approaches. Over to you, Ashikur.
Thank you, sir. Respected panel's member, ladies and gentlemen, fellow participants, good morning and assalamu alaikum. I am honored to presenting today at MSF Scientific Days Asia 2025. My presentation actually focus on mental health interventions for caregivers of children with neurodevelopment disorder. This is the scenario of Bangladesh, and this topic addresses a crucial yet often overlooked dimensions of healthcare, the psychological well-being of the caregivers of the neurodevelopment childs. In the next few minutes, I will share insights from our work, discuss the interventions we implemented, and highlight their impact on caregivers' mental health, family functioning, and overall child outcome. In near-developing countries like Bangladesh, neurodevelopment disorder is more discussed but less focused topics. We discussed a lot about neurodevelopment disorder, but we can't focus on their solution or their prevention. In 2019, our team conducted a research about the mental health conditions of the parents of neurodevelopment disorder childs. And after 3 years of the research, we found that about 85 to 89% caregivers had mental health issues like depression, anxiety, stress. Then we tried to focus on the solution of this problem and discuss with our government, our ministry, and they ordered us to create or established a formulated intervention program to reduce this type of mental health issues. For this reason, we try to test an emotional intelligence-based intervention that could help parents on children with neurodevelopment disorders. And we try to see whether the program could reduce the mental stress and improve their mental health problems and their well-beings, to check if this intervention could build the confidence level in the parents about caring of their children. Not only that, we try to measure any changes in parents' emotional skills, their satisfaction and relations after the program, to assess whether the program was practical and acceptable for parents and could be integrated into existing health centers and also in our existing health systems, to gather information that could help improve long-term support for those caregivers of the children with neurodevelopment disorders in Bangladesh. So what is the actual story? Parents or caregivers of children with neurodevelopment disorders are suffering from higher stress, leading to compromised psychological well-being. Caregivers' psychological well-being is important for better child health, development, and functioning. Around 9 out of 10 parents who have children with neurodevelopment disorder suffer from moderate to severe stress. This study was conducted by our team, and this is the principal investigator was the dean of our preventive and social medicine of Bangladesh Medical University, Professor Dr. Mohammad Atikul Haq. Parenting stress is often related to child characteristics, their behavior, parenting style, coping strategies, supporting system. Different interventions are practiced to reduce this type of parenting stress around the world, like parenting training on parents training on parenting, child behavior and mindfulness, parent-child interaction, respite care, etc. So now about the method of our study. It was a cluster randomized control trial study. We conducted it in Shishu Bikash Kendra, which is known as the Child Development Center. We named it officially the Shishu Bikash Kendra in Bangla. And there is about 180 Shishu Bikash Kendra in Bangladesh, combining the public, private child developing center. We conducted it in our eight main medical college of hospitals situated in 8 divisions of Bangladesh. That's why we try to represent the data of our country representative data. About the population, parents of children having the neurodevelopment disorder was the population of our study. We basically targeted 5 types of neurodevelopment disorder, like autism spectrum disorder, attention deficit disorder, cerebral palsy, Down syndrome, and intellectual disability. Our sample was about 480, cluster number of 8 and size was 60. That means in 8 centers, we targeted about 30 children and there are 60 parents. In 8 centers, our total sample size was 480. We targeted the parents of 18 to 15 years of old and parents having children with serious sensory impairments like deafness or blindness, oxygen dependency due to the chronic lung disease or any other chronic diseases. We excluded the parents and parents who need the pharmacological management for mental illness and is in the initial assessment also excluded from the study. We got 2 types of ethical approval, approval from our main institutional review board of Bangladesh Medical University, and as it is a clinical trial, we also registered it in clinicaltrial.gov. So this is our interventional method. Interventional method, we divided it into 3 parts, parents counseling and training parts, mobile application parts, and a diary parts. Parents counseling and training parts, it was a 4-hour session training, 2 sessions, 1 week apart, and in every session there was 12 to 15 in each group of parents. We developed an intervention tool, mobile app. We named it in Bangla Monokotha, which means the speech of our heart, the speech of our feelings. This was a parents' emotional intelligence network mobile app in which the parents can practice the emotional intelligence based theories, sees the documents and audios and videos which is based on our intervention program. We also created a diary or a task-based diary, which is, again, we named it in Bangla Anubhuti Diary, which is known as the diary of our feelings. It is a practice guide for emotional intelligence. That's the 3 main tools for our intervention program. We divided the 2 groups into, divided the whole population in 2 groups. One group is for 4 cluster and group B was in 4 cluster. One group was the intervention group and one group was the waitlist control group. Group A received the intervention and before the post data collection, and group B was got the intervention program after the post interventional data collection. Now about the result, about 80% population completed the whole study. That's mean we got the pre-data collection, the intervention program, and the post-data collection from them, and 20%, near about 20% was dropout in different stages of the study. What is the key outcomes? We saw that, you can see that the intervention and in control group, we focused here in 4 traits, the trait emotional intelligence, parental stress, parental self-efficacy and DAS score. Due to the intervention program, before and after intervention results showed that in the intervention group, the trait emotional intelligence increases, parental stress decreased, and parental self-efficacy also increases a little amount. This is the intervention group results. You can see that parental self-efficacy increases 16.17% after the intervention, where the trait emotional emotional intelligence increases 36.4%, and parental stress, which is our main focus, it is decreases about 26.7% after the intervention. This study also has some limitations. Short follow-up period may not capture long-term effects as it was a pilot study. So it was difficult for us to get the long-term follow-up. Then limited sample size. Again, it was a public pilot study, so we focused only the 8 representative Shishu Vikas Kendra and Child Development Center of our country. Self-reported measures may have introduced some response bias. This did not assess the border community and family level influences in depth. What should we learn? Emotional intelligence training is visible within the Shishu Vikas Kendra and accepted by the parents. Implementation fidelity is key. Trained facilitators ensure high engagement and need for integrated caregiver mental health support within public health infrastructure. Improve parental emotional well-being positively influences childcare and family dynamics. The approach can be scaled to other Shishu Vikas Kendras and integrated into national child development programs, supported advocacy for caregiver mental health as a public health priority. It will be great pleasure for me to tell about you that our government already accepted our result and they are committed us to put this program into the primary healthcare system of our country, and soon we will manage it in the actual level of our primary healthcare system. We sincerely thank the parents and the caregivers who participate in the study for the time and openness. Gratitude to the child development centers and their staffs for facilitating the intervention and the data collection. We acknowledge the Ministry of Health and Family Welfare and collaborating partners from their collaboration in Bangladesh. This project was funded by the Integrated Health Science Research and Development Fund, Ministry of Health and Family Planning, Bangladesh. This is some pictures of our projects, qualitative data collection. This is the intervention development workshops photos. We got the piloting programs both on fathers and on mothers before the data collection. After that, we trained the field investigators. Then baseline data collections happen. We trained the child psychologists who then put the intervention program to the parents. Different intervention program happened in different Shishu Vikas Kendra. And thank you all for patient hearing.
Thank you, Dr. Rahman. So the presentations are concluded now. So we'll, because we are running behind schedule by about, I think, 10-15 minutes, but we'll have 10 minutes for Q&A. So the floor is open now to ask questions. We'll have 3 questions first, and then we'll get the presenters to respond, and someone is checking the online questions as well. Okay? So the floor is open. Please raise your hand and we'll give you the mic. Any questions, comments, and please keep your questions very short, comments very short, please. Yes, please. Can we have the mic here to the front table?
Yeah, these presentations are very interesting. So I'm asking the question from the Dr. Dharmadas. Yeah, in your, how did you come to your conclusions? Like, did you statistically analyze, and what are the sample size and all?
No, actually, I don't have the statistic analysis, but the feedback was there. Like, not like there was no sample size. It included all the staff members. I was the head of the institute, so all the staff members were like they had the opportunity to participate. But what we analyze is from the feedbacks, like how many feedbacks we are getting. And initially, it was not, as I said, very few feedbacks, but later it grew more. And also, as a head of institution, the amount of complaints I received, because day to day we are receiving a lot of conflicts. So likewise, but no sample size.
Yeah, what are the inclusion criteria for you doing?
No inclusion. It's all the staff members were involved in the hospital.
Ah, okay. Thank you.
Now that we have Dr. Madhav answering the question, can I ask a question from you? That is, the Sahudra Danau, how is it different to the traditional counseling programs?
Yes, sir. Now the traditional counseling program, because especially this is in a rural setting. If someone goes to a counseling session, it's like they fear that their confidentiality, or even attending a counseling session will make them highlighted in this thing. So basically, sometimes they wanted to just to express their concern only. So we had this confidentiality system, so they can express their views. And in the monthly forums, that is addressed in open forum, not the individual advice. But if they need more individual counseling, we are in that session, our expert will provide the numbers so they can contact them.
Thank you. Any other questions? Yeah, Dr. Susi Pereira, and then Sir.
They're not really questions, but just some observations. And because the ASHA program in India has been there for a long time, and probably this is a good, maybe there are so many observations like this, but these kind of studies provide insight into how the programs can be made more sustainable, because I believe with these issues there can be a high turnover of the people who are trained as ASHAs. And also there was one observation about that they refuse to enter into places, if I understood right, when they are menstruating. But how would others know that they are menstruating? That is also another issue. And overall, I think most of the presenters highlighted the mental well-being of professionals and carers. So that is something that is very important that we address. Thank you.
Ma'am, regarding the menstruation part, these women are elected from their own communities. So these communities are very closely attached with each other. And the upbringing of us as a women, we are already instilled that we are not supposed to be going to the temples when we are menstruating. So this thought already place them at a very regretting stage. And when these women are going and approaching, so somehow they are telling themselves that this is not the time period I should be touching. Like in villages, if elderly women is there, then the younger one has to touch the feet. So they are not doing that. It gives indication that she should not be doing it right now because of her caste, maybe socio-economic background, or her psychological stage. So this is something which has come up in the study, and it is already highlighted in some other aspects as well. But through my study, I could identify this is also one of the challenging factor, and it is considered a big taboo, especially in Uttarakhand.
Nidhi, can I ask you one other question now? This ASHA program had been there for decades now, right? Do you recommend any policy change based on your ground experience?
Definitely, sir. There can be many, but one I would like to highlight is something related to area-specific incentives can be done, because this is one of the most challenging thing for these ASHA workers, that for winter season the sunset is happening at 4 o'clock or 5 o'clock. Beyond that they cannot go out for the services. So if we can put a specific time period to it, and if the region is specific we can make it, then the remuneration can be accordingly, because nowadays it is similar for the plains as well as the hilly areas. So this can be done.
Thank you, excellent. So those policymakers from India, I think the recommendation is area-specific incentives for the workers and more recognition of the realities in which they work. Thank you. Any other questions from the floor? Yes, please.
Yeah, my name is Manaf. I'm the treasurer for MSF South Asia. Thank you very much for this presentation. I think I also would like to touch on the Dr. Dharma Dasa's work. I think it was a beautiful piece of work during this whole crisis time. And I would like to also know that, I think this carers' mental health well-being and the support is a very important part in the whole spectrum. But I think in Sri Lankan context, which is, we know our hospitals, how busy, how critical, and how much lack of staff, etc. And you managed to do that within this challenging time. So I would like to know how much of this being taken into the system in other hospitals. Are they practicing, able to learn from you? And I think it is very, very important that a piece of work, but it's been quite neglected or ignored, or it is quite far from the day-to-day life. So I would like to hear from you, has this been taken in, or how is it going with the other influencing the system? Thank you.
Thank you very much for the comment. I think we did it in 2022. This was started, but recently I think from our Director General of Health Service, he has issued a letter to all the health staff, all the hospitals and the healthcare institution to get these suggestion boxes for the health staff, because we had these suggestion boxes and everything for the patients, not the healthcare staff. After there was a very tragic incident in Anuradhapura where a female doctor was harassed, and after that there were a lot of initiatives being taken, and this sort of system now from the top they have issued a circular to have this sort of suggestion boxes recently. Thank you.
Thank you. Are there any questions online? Or Dr. Asha, you would like to say something, or before we conclude the session?
Is there any question?
Yeah, there's one question online.
Okay, can we take that and then come to you? Yeah?
Yeah. The question is for Dr. Kachu Vilayil. Did you see any effect on mental health of the patients to whom the family caregivers provided long-term care after your intervention? If yes, can you please explain?
Dr. Asha?
Okay, can you one more time ask the question?
Did you see any effect on the mental health of patients to whom the family who were provided long-term care after your intervention? If yes, can you please explain?
Actually, I haven't done any intervention for the in the context. Actually, I tried to see what are the capabilities needed by these carers to maintain their well-being while providing care. So there is no intervention as such. Yes, the mental health of the patient or the carers is influencing the.
I think the connection is lost. So basically, there was no intervention. That's
The
what
medical
she said.
carer in that way, but I haven't done any.
Yeah. Thank you, Asha. Thank you. Last question, please.
Hi, this is Akash. I am presenting under the exhibition's innovation category. My question is for Dr. Nidhi. Ma'am, do you think any area where technology can assist the services that ASHA workers provide?
Technology as in, like, do you have something in your mind or...
Like for example, in Jharkhand,
Yeah.
CSR corporate social services, they provide electronic two-wheelers for mobility. So do you think there is any other space where we can explore technology?
Yeah, actually that can be done, but again the cultural aspect come into play there, because these are women who don't have autonomy regarding the finances as well as the decision making. So firstly we need to engage as a community, their husbands, and then the innovation can be bring in to place. But yeah, something related to the training modules can be done, and they can be trained in a way for the emergency and the preparedness regarding that. So I think that aspect can be explored, but yeah, I need to think and people need to work on it.
Training modules is what I'll pick up. Thank you. Thank
Yeah,
you.
thanks.
Thank you, and I think we'll conclude the session. I would like to request all of you, the case study that I presented through the video, you can see the timeline and that presentation outside. There's an exhibition outside. So please, after lunch or during the lunch break, please take a look at those exhibits as well. What I opened up was the introduction to the exhibition. Thank you, and over to you.
Thank you, Dr. Vinya, for chairing the session and for the video presentation, highlighting how community-led action sustained care during times of social upheaval. Thank you to all our presenters for the insightful, thought-provoking presentations and shedding light on the often overlooked heroes of healthcare. ASHA workers... low-cost sustainable solutions to innovation, mental and social burdens of caregivers, and innovative long-term support systems. Now we'll move forward to session 2. The theme of the session is Crisis to Resilience, Adaptations Amidst Emergencies. In this session, we'll explore how communities are adapting and building resilience in the face of crisis. Today's presentations will highlight innovative approaches to addressing the complex health and social challenges exacerbated by emergencies, with a focus on sustainability, rights-based approaches, community ownership, and holistic interventions. We begin with a 5-minute spotlight from Kerala, India. Please welcome B. Hari Govind from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Thiruvananthapuram, India, presenting Exploring Loneliness and Social Isolation Among Adults in Kerala.
Good afternoon, everyone. My name is Hari Govind, and I hail from the state of Kerala in India. Recently, I completed my post-graduation in public health from Sri Chitra Tirunal Institute for Medical Sciences and Technology, and the study titled Exploring Loneliness and Social Isolation Among Emerging Adults in Kerala was conducted as part of my post-graduation. I am here to introduce my topic and welcome you all to my exhibition space, which is right adjacent to the exit towards your left. So why loneliness and social isolation per se? Loneliness and social isolation have been gaining increasing recognition across the globe. And WHO Commission on Social Connection states, anyone, anywhere can be lonely or socially isolated. Across all ages and regions, loneliness and social isolation have serious impacts on our physical and mental health and the well-being of our communities and society. When you look into the kind of studies conducted on loneliness and social isolation, most of them are centered around Western nations such as USA, UK, and European nations. Theories have been developed around loneliness, and even scales to measure loneliness and social isolation have also emerged. But these have been developed and validated in the Western context. Researchers working on loneliness and social isolation have stressed the need to conduct studies in varying cultural contexts to understand the topic first before measuring it through scales. So why I did this study is to see whether fundamentally the concept of loneliness is different in a cultural context like India, whether we can adopt scales as such, or do we need to tailor it to the local context. So what I set out to find is to explain loneliness, social isolation, and its perceived causes from the perspective of emerging adults who are a category between 18 to 29 years of age, and to document the coping mechanisms that they employ in dealing with these problems. And for this, I adopted a qualitative method of inquiry through an inductive approach using 3 methods: grid elaboration, in-depth interviews, and photo voice from the participants. For validating the findings, I conducted 2 focus group discussions. And these are my research findings in a brief. Loneliness is a negative feeling or a state of non-belongingness and helplessness. It is associated with negative emotions such as intense sadness, anger, frustration, anxiety, and restlessness, all which have been seen to be precursors to depression. Fundamentally, it is different from the state of being alone, which is positive in nature and which participants remarked as peaceful for them. Social isolation, on the other hand, is experiential and not a feeling. It is a negative experience of being ignored, pressurized, excluded, or abandoned. Self-isolation is different from social isolation and is a positive experience. It's a choice. You choose to be self-isolated. It's an act of preservation from toxic situations. Causes of loneliness are many, but the main causes include pregnancy, not having anyone to talk to, loss of mentorship such as the loss of your parents, and breakup from a romantic relationship. Causes of social isolation could be your identity, which could be your religious identity, your migrant identity, linguistic identity, or even your sexual identity, and also your pregnancy status. Coping for loneliness indicated an urge to combat it, so people found safety in communities or groups, such as LGBTQ support groups, engaging in productive activities such as art and craft, seeking professional help, talking to oneself, or even AI chatbots, engaging with pets, binge eating, and crying. Coping for isolation, on the other hand, indicated distress, idioms of distress. People vented their frustration through verbal fights, they threw things, and they also cried. So, in a nutshell, what you will find in my exhibition space outside are photographic depictions and sketches of my main findings, quotations from my interviews and focus group discussions, music, movies, and books which illustrate loneliness and social isolation, which I had referred to my study, as well as I got suggested from my participants. And most important of all, a reflections corner for you to reflect on your experiences of the same. So if I were to describe this crowd, this audience in one word, that is diversity. We have people from different geographies, different cultural contexts, different professional backgrounds, and I'm keenly interested to know how loneliness and social isolation you have experienced or your peers might have experienced. So please do drop by my exhibition space. I welcome you all. Let's have a wonderful discussion and a joyful learning. Wishing everybody a day of wonderful learning and discussion. Thank you, everyone.
Thank you for reminding us of the overlooked impact of social isolation in young adults. Moving on to the oral presentations, this session will be chaired by Dr. Santusha Fernando, Senior Lecturer in Medical Humanities at the Faculty of Medicine, University of Colombo. With expertise in community medicine and a strong research background in non-communicable diseases, gender, and planetary health, Dr. Fernando also heads the international unit of the UCFM and brings with her invaluable insight and leadership to chair this session on crisis to resilience adaptations amongst emergencies. Please welcome on stage the chair for the session, Dr. Santusha Fernando. I would also like to invite the presenters on stage. Dr. Kiloshini Hendavitrana, Ministry of Health, Anuradhapura, Sri Lanka. Dr. Thisara Pereira, Department of Geography, University of Colombo, Sri Lanka. Professor Fariha Haseen, Department of Public Health and Informatics, Bangladesh Medical University, Dhaka, Bangladesh. Ruma Kodakar, Andrew Clark, and Sarah Williams from Save the Children International will be joining us online. Over to you, Doctor.
Ladies and gentlemen, welcome to this session titled Crisis to Resilience, Adaptation Amidst Emergencies. I think many countries in Sri Lanka, in the region and the world, including Sri Lanka, is in a factory setting of some kind of an emergency, some kind of a crisis. We are all human beings and human societies striving to find some kind of a resting potential amidst the chaos and difficulty and instability. So in these environments, some people, some sections of science, some champions strive to find resilience, stability, sustainability in uncertain times. So it is my great pleasure first to introduce and invite Dr. Kiloshini Hendavitharana, our first speaker at this session, who will present a holistic community-based nutrition program and to improve school engagement among children in rural Sri Lanka, implementation during the COVID-19 pandemic. Dr. Kiloshini Hendavitharana is a dedicated physician serving at the Ministry of Health Sri Lanka. She's a committed social worker who plays an active role in supporting rural and underserved communities across the country through her involvement in the Kusak Pirunu Hisak charity. She has helped and led various humanitarian initiatives focused on healthcare access, nutritional support and education empowerment. Ladies and gentlemen, I would also like to share that this young doctor here is Sri Lanka's gift, one of Sri Lanka's gifts to humanity. This is the first time I'm meeting her. We will listen to her and see the transformatory work a ground level medical professional in Sri Lanka, so young, so inspiring, has done. It's my great pleasure to invite Kiloshini to the podium. Kiloshini, over to you.
Good afternoon, everyone, and thank you, Santosha Madam, for kind introduction. It's an honor to be here with you today to share my presentation on holistic community-based nutrition program to improve school engagement among children in rural Sri Lanka, implementation during COVID-19 pandemic. And before proceeding to the presentation, I would like to briefly introduce what is our social charity. The name is Kusak Pirunu Hisak, in English, full belly, full head. In short, Piku Pihi, we call it Piku Pihi. It has two branches. Full belly part covers the nutritional part, and the full head part covers the individual students' educational enhancing part. It comprises with a few sub-areas, student assistant programs, student teaching program, student educational support program, and infrastructure developing program and special projects. We started this charity around June 2022, and the members of this charity are fully working in voluntarily. They live in different areas of the world, including Sri Lanka. They all are Sri Lankan, and they serve this charity during past 2 to 3 years. And we focus on actually three main topics: nutrition, education, and community resilience. Moving to introduction, despite national progress, malnutrition remains a major concern, especially in rural Anuradhapura. Children and adolescents are highly vulnerable due to increased nutritional needs, limited nutritional awareness, and socioeconomic challenges. The COVID-19 pandemic intensified these challenges, increasing food insecurity, reducing access to health and nutritional services, and because of the prolongation of school closure, it impacts the mental health, physical activity, and peer interaction among school and adolescent children. Based on this background, our objective is to promote school engagement and improve the nutrition of school children and adolescents through a community-based intervention in rural Anuradhapura during and after pandemic. Let me introduce our methodology. This is the design is a non-experimental one. We are working in 4 districts: Anuradhapura, Polonnaruwa, Trincomalee, Mullaitiya, the map says, and our school selection criteria are based on the schools being rural, and the number of student count is fewer than 50. Let's move into the intervention. We focused on participatory planning and community involvement. We engaged key stakeholders, parents, public health inspectors, teachers, and principals, which promote enthusiasm toward addressing this main issue, the shared ownership and local decision making, which creating active community group to address this malnutrition problem. Secondly, we focused identifying and addressing real-world problems. We focused, as I said earlier, we focused on malnutrition, absenteeism, and food insecurity. Again, we tackled social determinants of health during and after COVID-19. This picture shows average school setting with a whole number of students and a whole number of staff. Third, we followed cyclic and reflective process. Community identified key problems. We mapped local assets. Together, we prioritized and implemented community-led solutions. We monitored progress and expanded the program based on reflection. Fourth, we focused implementation and observation with measurable outcomes. We tracked school engagement. We tracked donor network growth, and we tracked academic performance and attendance. We observed improvements in nutrition and family-school collaboration. All these pictures show the community and parent participation directly to this program. And also we supported school children with giving school essentials. We help them farming, we help them poultry, we help them farming and poultry, which in turn gives hand-on skills and some nutrition benefits. Fifth, we focused on empowerment and sustainability. We emphasized capacity building and community empowerment. Through a replicable model through transparent communication and scalable practices and documentation. Sixth, we focused communication and monitoring. We have established WhatsApp groups for each participating schools to support real-time coordination. The monitoring mechanism was implemented to track program progress, maintain accountability, and inform future adjustments and scaling. You can see all this remote monitoring was done and communication done through WhatsApp groups. Then moving to results. Number of schools in the program you can see in 2024 December, the number is 144. But with the introduction of government school meal program, now we are serving 54 schools. Just we don't need to duplicate the main focus. So now we are serving 54, we scaled down. And in second graph, you can see the rapid progress of number of schools. We started July 2022 with 1 school, and during next 6 months, we supported 110 schools. And the number of children in the program also increased with time. In 2023, number of students we supported 4,823. Every day we provide lunch for those 4,800. And again, after reintroduction of government meal plans, we scaled down to 1,600. Now we are feeding these 1,600 daily. And looking at the donors count, June we started with 1 donor, and now it's expanding. We have donor base 382 from all over the world, all Sri Lankan. According to the principal's reports, community participation and school collaboration increased by 40%. School engagement rose by 80% with principal reporting improved academic performance and attendance. In conclusion, we have few limiting factors. There were monitoring limitations, and our findings were context specific, so results may not generalize beyond rural Anuradhapura. And we have limited long-term data, so full impact on health and academic outcomes still being observed. Lesson learned through this program: community ownership is key to sustainability and scale up. Digital tools like WhatsApp are powerful for low-cost coordination, especially for remote coordination and monitoring. Transparent communication builds trust and increases donor engagement. Holistic approaches, including nutrition, education, infrastructure, yield greater impact. Flexibility in design allows programs to adapt to evolving local needs. Our outcomes: improved school engagement, attendance and academic performance. The critical success factors were consistent nutrition and community involvement. The program demonstrates a scalable, community-led model. It strengthens cross-sector collaboration between health and education. It leverages low-cost tools like WhatsApp for coordination and monitoring. Our program supports integration of nutrition program into rural school systems. It provides evidence for donor investment and policy-level support, relevant for addressing food insecurity and educational inequality. Our next step is doing more towards full head part, moving to helping food student assistance programs, teaching programs where teachers are not available, and infrastructure development, including toilets, school buildings, and play areas, libraries, computer rooms, like that. Take home message: community-driven nutrition programs are not just about feeding children. They are a catalyst for improving education, well-being, and local empowerment. When schools, families, and communities work together, lasting change is possible. I would like to acknowledge and thank all these people, the generous donors, and school community, principals, teachers, children, parents, and government officers and volunteer group members. The most important fact I want to note is children come to school not for learning, just for eating. Thank you.
Thank you, Kiloshini, with that very powerful post-COVID message about the sad reality of some parts of Sri Lanka. We move on to our next presentation, Understanding Barriers and Facilitators to Adolescent Sexual and Reproductive Health Among Climate-Displaced Communities in Urban Bangladesh, a CFIR guided qualitative study. Our presenter is Professor Fariha Haseen. Professor Dr. Fariha Haseen is the head of the Division of Reproductive and Child Health and Director of Center for Gender and Women's Health Research at the Department of Public Health and Informatics, Bangladesh Medical University. With over 30 years of experience, she specializes in leadership, gender, adolescent health, climate change, sexual and reproductive health, and health systems. She is the recipient of numerous prestigious fellowships internationally, and she also is a member of the Institutional Review Board of BMU and the International Papilloma Virus Society. Dr. Haseen will be joining us online. Over to you, Dr. Haseen.
Thank you, madam. Can you hear me?
Yes, we can.
Okay, thank you so much. So today I'm going to talk about understanding barriers and facilitators to addressing sexual and reproductive health among climate-displaced communities in urban Bangladesh. CFIR guided qualitative study. Next slide, please. So this is our research team. Next slide, please. I would like to say something about our institution. So Bangladesh Medical University stands as the pinnacle of postgraduate medical education in Bangladesh, tracing its roots back to the Institute of Postgraduate Medical Research, established in December 1965. In 1998, the government transformed IPGMR into a medical university, aiming to enhance Bangladesh capacity for advanced medical education and research. One of the major faculties of the Bangladesh Medical University is the Faculty of Preventive and Social Medicine. Under this faculty, the Department of Public Health and Informatics is conducting significantly to research and develop to impact the lives of common people from the grassroots to the tertiary level. This department is equipped with several centers that not only enhance the health of the population, but also enhance the thoughts and research for the next generation of public health specialists. One such center under this department is the Center for Gender and Women's Health Research. This center was established to meet the goals of equality and equity for health access that advanced in science for all. Next slide. So now the introduction of my today's talk. We all know that climate change is an escalating driver of internal displacement in Bangladesh. Why? With river erosion, flooding, and salinity intrusion forcing rural families into urban areas, mainly in urban slums. The adolescent girls or female adolescents of those climate-displaced migrant families are more vulnerable to early marriage and poor sexual and reproductive health outcome, like early pregnancy. So it is very important to explore and understand the critical factors to understand the process of early marriage and what are the sexual and reproductive health consequences among these climate-displaced migrant adolescent girls. Next slide. So based on this introduction, we designed the study, and the aim of the study is to explore the factors shaping adolescent sexual and reproductive health and early marriage among displaced population in Dhaka's urban slums. We used consolidated framework for implementation research that is widely known as CFIR to identify actionable barriers and facilitators across key implementation domains. Next slide. Next, please. Thank you. So for the methodology, participants were purposely sampled from the climate displaced households in the Duaripara slum, Rupnagar, Mirpur, under the Dhaka North City Corporation, primarily originating from Bhola district. Here I would like to mention that there are certain slums in Dhaka city where some particular slums are there where the people are coming from the southern part of the Bangladesh. So this slum is like one of them, and particularly from the Bhola district, that is very southern part of Bangladesh, which is being affected by the climate change. So the families who are being displaced, they usually come to Dhaka and live in this slum. For that reason, we wanted to know actually what is happening to their adolescent girls' life. That's why we used the exploratory qualitative design, and this study was conducted between March to August 2024. The study got the ethical approval from the Institutional Review Board of Bangladesh Medical University. Next slide. So this study wanted to explore factors influencing early marriage practices, and also we wanted to explore sexual and reproductive health consequences among these climate displaced migrant adolescent girls. This was a qualitative study, so we conducted 27 in-depth interviews with married and unmarried female adolescents. We also conducted key informing interview with some of the parents of these female adolescents and other critical stakeholders from that slum area. And we also conducted 2 focus group discussion, one with married female adolescents, another with unmarried female adolescents. Next slide. So as I mentioned earlier, we wanted to use the Consolidated Framework for Implementation Research, CFIR, which we all know that it is organized and present the findings across its 5 domains. Next slide. So here now I would like to share the results in very brief. As we all know that this was a qualitative research, so data were thematically analyzed and we used the CFIR framework. And this CFIR framework guided us to identify the key factors across 5 domains of characteristics. One is individual characteristic, another one is outer setting, then the inner setting, intervention, and also the implementation process. So when we explored the individual level, we found that adolescents are lacked autonomy and SRH knowledge. But we also found that they showed motivation to participate when engaged through peer-led strategies. So there we also found a positive and negative norms, both are comprising in the slum level. And when we wanted to explore the outer setting, we found that climate-induced economic strain and limited healthcare access in slum area reinforced child marriage as a coping mechanism for the family. Though we also saw that there is an increasing parental awareness and adolescents' demand for SRE services indicated evolving norms. Why it is happening? Because when these displaced families are coming in Dhaka and living in the slum area, we also found that there are certain organizations, they are working with the slum families. But those families who were living in this slum area from earlier or like a few years back, they are more empowered than this newly displaced population. So when they see that this kind of empowerment is happening, they are also becoming the or included the part of empowerment. So we saw that though initially they are very much vulnerable, but with time they also have some of their certain coping mechanism, and they also wanted to shift the negative consequences or norms to a positive norms. Next slide. So what about the inner setting? Definitely this is a very critical part. We found that poverty and overcrowding, like any slum, and disruption of education heightened the risks. But delaying marriage was more acceptable when linked to education and employment. That means if the families are gaining the advantage of the continuing the education, or if there is any opportunity for the employment, then they might change their decision to give back the early marriage to their adolescent, very young adolescent girls. When we try to understand the intervention-related barriers, because we have seen there are several different kind of intervention is going on different part of the slum. So what we found there, though the interventions is going there, but there are inadequate financial incentive and misconceptions about child marriage law, while community familiarity with health campaign was a key facilitator. And these families, especially the parents and the married adolescents, reported to us that this health campaign is a very easy intervention for them to change their norm. But we also have to keep in mind, as this is the very deep-rooted norm, so sometimes these short-term intervention may not work for the sustainability or for the long time. And we also saw the implementation facilitators. We found multiple implementation facilitators. Those are included adolescent-friendly clinic, vocational program, community-driven campaign, and all of which showed that potential to shift norms and fill service gap. Next slide. So this study definitely has some limitation. So what was that? The study scope and data constraint, like conducted in one Dhaka slum cluster with mainly female adolescent participants, may not give us the whole or all information. Findings may not be represent all displaced community as well. But there was a great lesson learned for us. What was that? If I want to tell you regarding the program insight, that was the peer-led approach, linking education, employment to delayed marriage, and leveraging community familiarity with health campaign are effective entry point for sexual and reproductive engagement for the young female adolescents who are the member of the displaced family members. And we also learned system level learning, that was multi-level barrier really required special attention, like integrated solution that address both structural constraint like poverty, limited services, and also the individual empowerment for lasting change. And we can also wanted to say that if these interventions are going on in a sustainable way, then we can see some changes in a long way. Next slide. So in conclusion, I wanted to say that using the CFIR model enabled a systematic exploration of multi-level influence on adolescent sexual and reproductive health and early marriage in displaced communities. I also wanted to conclude that it facilitated the identification of context-specific barriers, and facilitators and illuminated how individual, structural, and programmatic elements intersect to shape the outcome of the life of these very young female adolescent girls. And lastly, I wanted to say that this approach offers valuable insight for designing adaptive, equity-focused intervention that are responsive to the complex realities of climate-induced displacement in Bangladesh. Next slide. So I would like to acknowledge the Ministry of Science and Technology for the funding of this study, the study participants of Duaripara Slum of Rupnagar, Dhaka, and definitely Department of Public Health and Informatics of Bangladesh Medical University for giving us an opportunity to conduct this study. Next slide. Thank you so much for your patience hearing.
Thank you, Dr. Hasina Hussain. I kindly request all the speakers to restrict their speaking time to 10 minutes in the interest of time. After that very insightful presentation, we move on to the next presentation, Climate-Induced Livelihood Transformations and Fertility Preferences Against Females, Examples from Sri Lanka. To present this, I have the pleasure of inviting Dr. Thisara Pereira, sitting right next to me. He is a senior lecturer in human geography attached to the Department of Geography, University of Colombo. He has a BA Special in Geography from University of Colombo, MSc in Environment Management from University of Sri Jayawardenepura, and a PhD in Geography from the University of Huddersfield in United Kingdom. He authored several articles in many index journals, including Web of Science, contributing insights to the global body of knowledge, and his research interests are in medical geography, spatial epidemiology, and disaster management. He's practically a brother of the medical world, I think, from humanities. Over to you, Dr. Thisara Pereira. Yes.
Good afternoon, everyone. I'm Tisaragitika Pereira from the Department of Geography, University of Colombo. Today's my presentation is about climate-induced livelihood transformation and fertility preferences among females, examples from Sri Lanka. So this is the content of today's presentation. Let's move forward with the introduction. So this research is basically about the droughts, and we all know the impacts of droughts as a slow onset disaster in Sri Lanka. So in 2016, more than 800,000 people in Sri Lanka have been affected due to droughts. But most of the research, most of the studies in Sri Lanka have been conducted about the environmental challenges and the risk and also the adaptation strategies to droughts, but not about the gender dimension or demographics of drought cases. So in this study, we aim to identify the fertility trends and how it affects the severity of the lengthy droughts into Sri Lankan district, how it affects on women's economic and social well-being and use of sexual and reproductive health services and fertility intentions. So there are 4 objectives in this research. So we first identify the spatial and temporal trends of Sri Lanka, and secondly to identify the potential impacts of droughts on fertility and reproductive health. Thirdly, to develop a policy framework to mitigate these impacts, and fourthly, to develop a recommendation to address these issues. So in this study, for the methodology, there were 2 phases. So we selected 2 districts, as I mentioned before, Anuradhapura and Hambantota. So we collected data from the Google Climate Engine regarding the rainfall data in Sri Lanka, and also we collected demographic data from Department of Census and Statistics. So based on the Google Climate Engine data, so we prepared some maps regarding the rainfall intensities in each district. So you can see here within the districts in Hambantota and Anuradhapura, so there were some changes, spatial variation among how heat affects each region. So the red color represent the most affected regions according to the SPI index. So these maps represent Anuradhapura district, and these maps represented the Hambantota district. So based on the most affected Grama Nigadhari divisions or the village divisions in Sri Lanka, we selected 3 main most affected GN divisions in each district. From Anuradhapura we selected Lindabava, Timbiribawa and Kusumpura. For Hambantota we selected Bundala, Siriyagama and Julgamuwa. So in the second phase, so based on the selected GN divisions, we collected information, primary data, and before collecting primary data, to prepare the data collection instrument, we did a systematic review and find what are the key themes that discussed in the literature about droughts' impact on women and gender dimension. So in the data collection stage 2, we conducted 15 interviews, 8 focus group discussions, and also 10 key informant interviews. Based on the systematic review, we found out that in the global literature, there were research about how economic stability and it changed the fertility patterns, and how the health impacts affect the fertility, and also the intimate partner violence and the gender-specific vulnerabilities, and also there were some studies about regional differences in fertility responses to drought as well. So based on these key concepts, we prepared our data collection instrument, and these are some images for our data collection phase 2. And here we analyzed our data using the qualcoder, qualitative data analysis software, and also the systematic review. And this is the code book that we prepared for data analysis. And based on the results that we get from the key informant interviews, focus group discussion, so we found out that economic instability is the basic factor that affected during the droughts with most of these women. So there were some crop damages and also some job losses, and also they have to be adopted with loans as well. And also there were some impacts on food insecurity, especially when it comes to economic instability. So there were some water scarcity cases as well. And also one of the most highlighted factor was the animal-induced agriculture damage, especially by elephants and also by monkeys in these regions. And also due to this food insecurity and also the economic instability of these areas, So the women's responsibilities have been changed over the time. So we identified that, so they have to adapt more strategies to cope with these scenarios in drought areas, like water retrieval and collection, and also the economic role have been changed, and the social role has been changed, and also the sex roles, the gender role has been changed in these regions. And also it affects the women's health as well. So the high temperature, so there were some skin diseases in those regions, and also their consumption unsafe water, and also the water quality issues has been identified in those regions, and also the poor hygiene infrastructure facilities also there in these districts during the droughts. So based on the data collected during the second phase of the study, so we prepared the final framework and we validated it using Delphi technique and also using roundtable discussion. So in this framework we identified 3 main layers. So the research is all about how droughts impact on the fertility. So we found out that in the first layer, the most of the studies is about how climate changes and droughts impacts on the fertility, and we found out that it's more indirect relationship between drought and the fertility trends, especially the economic instability and the foods insecurity, and also how the nutrition gaps has been available in these regions during droughts. So based on this economic instability, the women's responsibilities has been changed over time. So the family role, the gender role, and also economic role as well as social role have been changed over time. So due to these things, in the third layer we identified that the fertility decisions, the number of children have been declined, and also there were some preference on the early marriage, but still the number of children and their fertility preferences have been declined over the time during this drought. And there were some gender-based violences, and also we found out the gap between children also increased in these regions during drought period. So when it comes to the key findings of this research, so the economic instability is the main factor behind the droughts. So this economic instability indirectly and also sometimes directly affect the fertility patterns of those regions, and we identified the health impacts due to these droughts and how it impacts the fertility of these people. And there were some cases about the intimate partner violence during droughts, and there were some gender-specific vulnerabilities in those regions, and also there were some regional differences, like the cases in Anuradhapura is a bit differ from Hambantota as well, and also there were declining trends on the number of children, and also the social role of the women have been changed over the time. So in conclusion, so we all know as a slow onset disaster, drought severely affects the livelihood, water resources, economic instability, and also the reproductive health. But still, there were some gaps regarding how it affects the demographics of a selected population. So the economic instability leads to food insecurity, and it leads to migration, and it leads to some fertility differences as well. So this is the first time in Sri Lankan context we are studying about how drought, how disasters affect on fertility trends in a selected region. So families respond to financial hardships by delaying childbirth, and they opting for early marriages, and also sometimes they are facing intimate partner violence cases as well. So we think that we need some kind of effective interventions to include sustainable water management, climate resilient agriculture, women's economic empowerment, and also most importantly, so we need some improved reproductive health services, especially in these regions, to cope with these scenarios. And also finally, we need some kind of a holistic, multidimensional policy approach in these regions where we can interconnect social, economic, and health challenges for these drought-affected communities. So that's the end of my presentation. Thank you very much.
Thank you, Dr. Pereira. Our speakers here are truly illuminating some of the dark corners of society and realities. With that wonderful presentation, we go to the final joint presentation, a randomized controlled trial of group-based intervention to improve maternal mental health and child well-being in Cox's Bazar in Rohingya communities. The presenters are Ruma Khondekar, Andrew Clark, and Sarah Williams. I'll quickly introduce our three speakers. Ruma Khondekar is a senior clinical psychologist in Bangladesh with over 20 years of experience in child and adult mental health for displaced populations, refugees, and victims of trauma, addiction, and violence-related care. She has worked with the CSI, HI, UNDP, and other national and international agencies in Bangladesh, Myanmar, Thailand, and Ukraine. She currently serves as the MHPSS advisor for the Save the Children in Bangladesh. Andrew Clark is a senior health advisor for the Save the Children UK, working in pediatrics and public health for over 30 years. He supports clinical and public health programs for children and families in countries including Yemen, Bangladesh, Nepal, Ethiopia, and Malawi, and a research portfolio trialing new approaches to long-term challenges in maternal and child health. He's an honorary clinical researcher at the Lancaster University and has interest in human rights, mental health, climate change, and health equity. The final presenter of this joint presentation is Sarah Williams. Sarah Williams is a global health professional with over 25 years of experience, primarily focused on maternal and newborn health. With a background in midwifery, she has worked across UK, Africa, Asia in roles including teaching, training, mentoring, operational research, and program leadership. She currently serves as the senior maternal and newborn health advisor at Save the Children UK, providing technical support to programs in low and middle income countries, both remotely and on ground. Her career is underpinned by a strong focus on health, equity, and the right of all people for quality care. So these are the joint presenters of our third presentation, which is a randomized clinical trial on a group-based intervention to improve maternal and maternal mental health and child well-being in Cox's Bazar in Rohingya communities. Over to you, ladies and gentlemen, who are joining us online.
Thank you, Honorable Chairperson. So, hello everyone. It is a pleasure to be here today. I am presenting on behalf of a large team, including colleagues at Save the Children, Manchester Global Foundation, and Pakistan Institute of Living and Learning. I will be talking about a randomized controlled trial we have been conducting in Cox's Bazar, Bangladesh, and testing an interesting intervention to improve maternal mental health and child well-being. We have called it the Bandhan Project, as Bandhan is a Bengali word, reflects attachment and bonding in a relationship, especially with family members. Next slide, please. So why actually we are conducting this research is very important to understand. So the problem we are interested in relates to maternal mental health, its importance for women, and its effect on child outcomes. Poor maternal mental health is common, but often goes unaddressed. There is much evidence about the effect of maternal mental health on child outcomes, and this includes increased risk of premature birth, low birth weight newborns, poor bonding, parenting capacity, inadequate child stimulation, and increased difficulty with infant feeding. Adverse effects on cognitive, emotional development, and nutrition. So in setting where maternal mental health is particularly at risk, it becomes important for both mother and their child to find effective and feasible ways to improve that. Next slide, please. So why we are implementing this RCT? So it's in Cox's Bazar. I'm just checking, yeah. Sorry, okay. It is the context for the study, the Rohingya response, and the camps near the border of Myanmar. Many families have been living in the camps since 2017. It's highly dense, 1.3 million people living in very tiny place, and many people living without proper housing, hygiene, and sanitation, or spaces for play. They also face daily security threats, intra-camp gang violence, and stress. Families are reliant on food rations, but funding at these and other essential services has been radically cut. The Rohingya response have generally been forgotten nowadays, as the world moved on to focus on other crises. Next slide, please.
Well, this is the intervention we tested. And Learn Through Play Plus is a combination of two established interventions. LTP is a parenting program focused on child development. The plus part is really important, and this is the integration of LTP with elements of WHO's Thinking Healthy program, which includes simple cognitive restructuring techniques based on cognitive behavioral therapy. Most of the previous evidence has been drawn from studies in development settings, primarily Pakistan, but there's little related to use in humanitarian settings. LTP Plus is delivered in a group structure of 10 one-hour sessions, and importantly, can be delivered by non-mental health specialists. All that's needed is training in LTP Plus. We know often we can't affect people's fundamental circumstances, but this intervention aims to better equip mothers to develop longer-term coping strategies to support their resilience and functioning. Next slide, please. So this is the objective of our study, to evaluate the effectiveness of LTP Plus parenting intervention for reducing depression in Rohingya mothers of children 0 to 1 years in Cox's Bazar. And we measured depression using a patient health questionnaire 9, PHQ-9. Secondary objectives were reduction in anxiety, which was measured by GAD-7, Generalized Anxiety Disorder 7. And we also looked at improvement in health-related quality of life, perceived social support, knowledge and practice about child development, child health, nutrition, and development measures. Now, the study was a 2-arm cluster randomized controlled trial in 6 camps, so 3 intervention, 3 control, and 491 participants in total. Mothers had a child under the age of 1, and it's really important to note that we didn't screen for depression prior to their recruitment of the trial. The intervention was positioned as a training likely to be beneficial for all. So a universal intervention to reduce the possibility of stigma associated with participating. Next slide, please. So the trial took a long time to set up with development of materials, training permissions, and the fluid security situation in the camps. And we noted a low dropout rate. Over 90% of women attended 8 out of the 10 sessions. We felt this was encouraging. However, we're also mindful that a camp environment is much more controlled than many other settings. Next slide, please. So you can see the intervention and control camp groups were comparable in terms of main characteristics. For the baseline and midline data collection, the study was obliged to train and use existing enumerators who were very experienced in collecting routing data in camps. However, they were unfamiliar with mental health issues. Quality checking of our data and a review of the situational methods caused concerns about the quality of data, and primarily related to tools of psychological assessments, PHQ-9 and GAD-7. So based on this, we made the decision to train and use psychology graduates with strong linguistic compatibility to Rohingya mothers. So endlines resulted in a much more rigorous and viable data set. Next slide, please.
So these are the preliminary results for the primary outcome of depression. The top table shows the mean scores for intervention and control groups at baseline and endline using the PHQ-9, the patient health questionnaire that Sarah mentioned. And just keep in mind that the lower scores are better. We can see that there was an increase in mean scores for both intervention and control groups from baseline to endline, and we suspect that this is attributable to an increase in daily insecurity, such as violence and abductions, that was happening across all of the participating camps at that time, and also due to underreporting of PHQ-9 that we identified during the baseline data collection. However, at endline, and with more robust data collection in place, we found a large and significant difference between the two groups, with mothers in the control groups having much higher mean scores than those that had received intervention. The table below that in blue shows what the same data looks like for endline when looked in terms of the proportions of mothers with different levels of depression. And what we can see is that mothers in the intervention groups were far more likely to have scores suggestive of mild or low depression, and far less likely to have scores suggestive of moderate and severe depression. 44% of control group mothers had moderate levels of depression, and 24% had moderate to severe and severe depression, compared to 23% of intervention control group mothers that had moderate depression and only 3% with moderate to severe and severe. Next slide, please. The data on anxiety using the GAD-7 tool shows a similar picture. Again, lower score is better. The top table shows the mean scores for the intervention and control groups, and again, scores increased across both intervention and control from baseline to endline, but there was a greater and significant increase in mean scores in the control group. The table below in blue shows what this means when viewed according to the anxiety classification of the individual mothers, and you can see that far more women in the control group had GAD-7 scores that were indicative of moderate and severe anxiety than did mothers that had received the intervention. Next slide, please. We also looked at mothers' perception of quality of life using the EQ5D tool. This is a self-reporting tool that measures 5 domains covering quality of life and healthy functioning and combines them into an index. So a score of 0 is the worst possible health and 1 indicates full health. And again, we found a significant difference in mean scores between the intervention and control groups at endline. Next slide, please. EQ5D also includes a scale where participants are asked to rate their overall health from 0 to 100. And again, we found significantly greater perceptions of feeling healthy amongst intervention group mothers. Next slide, please.
In parallel to the quantitative measures and scales, we also collected qualitative data to better understand mothers' experiences and to add resonance and triangulation of the findings. So I'm sharing 2 statements of mothers here. So first one, when I was feeling really overwhelmed, it was hard to focus on the things I needed to do for my children. My mind was constantly racing, thinking about all the problems we had. I couldn't focus on anything for long. The sessions taught me how to manage my thoughts better, and that was made a difference in how I handle everything day to day. And the second statement, I would come to these sessions even if there were no snacks. And you can really relate the scarcity into the settings, and people are really need some additional support. So next slide, please.
So the full analysis of this complex data set is still to be completed, and particularly some of the elements relating to the child development outcomes. But we felt that the results so far were very encouraging, which is why we wanted to share them with you, and also pose some further questions that are important for decision making about the continued or expanded use of this intervention, either in Cox's Bazar or other settings. So as we move forward, we want to know more about whether similar benefits can be achieved with a shorter intervention, such as 6 sessions instead of 10. How long do these benefits last? Are we still able to measure improvements after a year? And we're also mindful that the subsequent effects on child health and development may take longer before those benefits are realized and measurable. So this is where we're probably heading next. Next slide, please.
So many people contributed to making the study possible in a really challenging setting and with a limited budget of just over $100,000. Some of those people include Professor Nusrat Hussain from Manchester Global Foundation, Taiba and Rabia from Pakistan Institute of Living and Learning, and really especially all the mothers who took part. And we'd like to thank them, and we'd like to thank you for listening. Thank you so much.
Thank you very much to our presenters here today. Okay, we have 10 minutes for discussion, is it? Okay, the floor is open for questions. Any questions to our speakers here on site or online? till some of the questions are, okay, someone wants to ask a question.
There is a question online.
Okay.
It's a query to Dr. Henda Vithrana. You said you implemented community-led solutions after mapping local assets for improving school attendance via CBNP. Could you please let us know what those solutions were, because I guess those were not explained.
Can you please repeat the question?
Yeah. You implemented community-led solutions. You said community-led solutions were implemented after mapping local assets for improving school attendance. Could you please let us know what those solutions were? Community-led solutions were.
Our setting, as I said earlier, we selected schools with two criteria. First is they should be rural schools, and other is the student count is less than 50. And the main limiting factor in this area is most of the time all parents are farmers or doing day-to-day things for earning. So we supported them. We invest some donations to invest to empower parents. So sometimes we have to give fishing boats, sometimes we have to give short-term crops and cows for dairy products, and sometimes we gave them we gave some means to empower them, and the priest in the area and the principals and teachers in the area did the major work, and these are the actual assets. We thought some teachers or some principals may not willing to proceed, but with the intention of doing something to their schools, we found that is the main asset we found, and some community workers around the vicinity, they helped us a lot. And again, I forgot to tell, we support families with poultry for egg farming. So this will indirectly increases their contribution. So we could do this thing. Yeah.
Thank you, Dr. Henda Vithrana. There is another question. It is for Andrew Clark. Did the trial include anything about mental health for women during the antenatal period?
Yeah, thank you for that question. The actual trial did not. The trial focused on the postnatal period, but the actual intervention is very suitable for antenatal or postnatal, just as it is for other target groups as well, such as fathers, couples, other groups that may be particularly vulnerable to chronic mental health threats to their mental health, such as perhaps families that have children with disabilities that were referred to in a previous presentation today as well. So, but because it was a trial, we needed to focus on a very specific group, and so for that purpose, it was postnatal women between birth and 12 months. But the actual, you're right to mention antenatal, and in practical operational application, this approach would be used with women antenatally as well, certainly.
Thank you.
Any other questions from the floor? There are two questions, I think. One at the back and one Dr. Susi.
Yeah, I would like to congratulate Dr. Henda Vithrana, because this is what she has done is something that the Ministry of Health, together with many stakeholders, try to do this during the economic downturn. When we put out the emergency nutrition plan, it was mentioned about linking donors to improve the nutritional status of the children, and this is, I think, we have to congratulate her, and this should be widely known of this example. this is, I mean, we really appreciate it. I really appreciate it. I'm no more in the ministry, but I think I really appreciate it. I would also like to make a comment on the fertility decline, and this is actually a subject that we are discussing now for the policy dialogues, which is leading to the next 10-year health policy. What we are seeing as determinants of fertility decline, it's the choice that they're making, and it's a choice that people are getting used to now, to have fewer numbers. But it happened suddenly over the last, probably last 2, 3, maybe 5. It's accelerated by the, the pandemic and all of that. But when people get used to, I mean, this trend, you relate it to the climate change and all of that. But with adaptation, people, it is not necessarily directly just the climate factor. This is, it's so many other things. It's not because climate, the changes, those things people will get used to that. But it's a choice that they have now fixated. So there's a lot of social science research that is needed to see how this can be changed. Of course, other countries are doing it with so much of incentives to actually the leave, the paid leave, the child caring, incentives for daycare and all of that, which is lacking in our countries.
Yeah, thank you, ma'am, for that valuable insight. So one thing I would like to highlight is, so first thing is that this is the first time we are studying about how droughts impacts on fertility. So when it comes to the secondary data about the systematic review and the available literature, so we didn't found anything in Google Scholar or Web of Science regarding this aspect. So I think the way forward should be, so we just covered 2 districts, Anuradhapura and Hambantota, and it's better to have some more evidences from other districts as well. And on the other hand, the important thing is, so drought is a slow onset disaster. So as per the forecasting outlines from the Department of Meteorology, so for Sri Lanka, it's about the wet zone is getting more wetter and the dry zone is getting more drier. So it means in the near future, we will see more such cases in Sri Lankan context. So it's better to have some kind of proactive approach rather than a reactive approach. So that's why I'm suggesting it's better to discuss or explore more on the aspect, especially for the policies as well. Thank you.
Thank you, Dr. Pereira.
Could I ask just one more question? Because
yes. Then we'll go to the lady at the back. Yes.
A lot of, the conversation was around the education systems being kind of jeopardized, and the lack of education which made early marriages and, these kind of things. Like what we heard in the morning on the medics on the street. I mean, are there interventions that are well documented on, education brought closer and education on wheels or something like that, so that that learning can be made more practical in different situations of disaster and settlements that have come up like this. Yeah.
Would any of the speakers like to take that question? Was that clear? I think, Madam, what you meant was that most of these interventions that we spoke about were probably nutritional interventions and so on, but when a crisis happens, whether other needs of populations like education, does that also flow in the same sort of manner and filters into society? I mean, I think that's a sort of a philosophical question for all of us to ponder with. May I, in the absence of a response, may I Anybody else like to comment on that from the floor? Okay, we will ponder over this over lunch. I will take one final question from, okay, there were two. I'll first go to yes, that raised hand at the back, and then I'll come to you, ma'am, yes.
Hi, sorry. So my name is Kasamirana Singh Arachige. I am an eco-psychology consultant as well as a co-director of the Biodiversity Project. I just had a small comment as well as a open question if anybody could answer. In terms of crisis to resilience, obviously when it says crisis, we have seen and witnessed and are enduring multiple crises at once, not just one crisis, but complex and interlinked crisis, which is the climate crisis. And I was wondering if the emotional aspect, such as the emotional distresses, exactly, such as anxiety, PTSD, even depression, are actually more prevalent and commonly found within the youth as well as children who are growing up with the concerns of the climate crisis, their house, them losing their own house, not being able to live on a livable planet. Those are big concerns amidst other concerns such as being in a vulnerable population, being in a vulnerable, in a marginalized community, and so on. So has there been effective strategies in encouraging either hope or resilience mechanisms in ensuring or providing resources for the youth, or in getting them engaged as well as I would like to also mention that many of the things that we have also spoke about, we also have given much priority to the mental health management mechanisms or methods that have also been introduced more towards a neo-colonial mental health management. And so I was also wondering, because from a Global South perspective, we are more communal. We have been more codependent amongst each other, but that is losing its value. That has been something that we are seeing as a trend that we are losing away from. And we are trying to become more independent, more self-oriented. And how can we ensure that community support is also there? How can we encourage that, but not create a codependence, not create a dependence on the providers, but create the dependence amongst creating resilience towards the community, towards the planet?
All right, so she is raising several questions. I would invite one of the speakers to take it. Yes, yes, yes. Please go ahead. I think.
Can I answer?
I think. Yeah. May I first ask?
Sorry, could I interject for a moment? Could the speakers please keep it concise? We are running about 1 hour late. Also for the audience, please keep your questions concise.
Yes,
we love the engaging discussions, but just in the interest of time. Thanks.
Yes, I will first go to Andrew for comment, and then followed by a quick comment later. Yes, Andrew, would you like to comment?
Yes, certainly. Just briefly, just two central, I think, observations and points, really. The first one in relation to the kind of multidimensional effects of climate change and undermining mental health in the whole population, but particularly children and young people. I think you're absolutely right to highlight that. And it's not just the effect of major events, it's the effect of chronic uncertainty, really, and how that undermines people's mental health, and particularly increases anxiety as such. I think for young people that's further pronounced, but fully documented and measured really at that point. In terms of responses to that, I'm not sure there are very good cohesive responses to that, but I am aware, having bit in the climate space and some of the larger programmatic and national responses to that there is a slow but increasing awareness of the impact of this on mental health, and also how actually undermined mental health actually interferes with people's ability to adapt. So at the very time when we need people to adapt most, complications like anxiety actually interfere with that. So it is gradually getting visibility and response within their plans. The second brief point in relation to what you said around the shift and the neocolonial and the differences in South Asia, I think it's entirely to be expected because you've got rapid urbanization and a lot of the communities that we're in working very closely together at the village level look very different in an urban setting. The challenge is how you recreate those community structures in rapidly changing urban areas. But that's a brief answer.
Thank you. With that, I think we are behind schedule. I kindly request those who are asking questions to limit the length of the question. May I take the final question and then go, we wrap up? Yes.
No, that's good. I think we can wrap up.
Oh, I'm sorry. No,
that's fine. I am a Save the Children colleague. I could always reach out to them over Teams. That's okay.
Are you sure? I'm sorry.
I
didn't mean
that's
to.
That's fine. We can go for lunch.
Okay.
Thank you, Dr. Santusha, for chairing this session, and to all our presenters. Okay, we are running, so we will shorten our lunch time. Could I please request all of you to be back here by 2 p.m. And if you've not finished your lunch or dessert, please bring it with you, but please be here by 2 p.m. Thank you. going to announce now.
Change the presentation.
Hi, everybody. We are starting in 5 minutes. Hi, everybody. Can everybody please come back? Also, can the MSF team start helping people in with their desserts? We will start. Where is Prashani? Because she was okay. Nadeem, is Firdos here? Is Firdos here? Firdos. Sorry, Prashani. Prashani, is Firdos here? Yes. Yes. Yeah. So it will be on, just put it on the stage, it's okay. Okay. Yeah, I just click on it and it comes, okay. Okay. Yeah, no, go take your time. But are they both here? And they are going to tell me to turn the presentation?
No, nothing like that. It will be done by Satya.
Okay. Okay.
So for this one, it's for interest. You can after that introduce the like we discussed.
Yeah, like we did the last session. Okay. Okay. Welcome to session 3, Co-Creating Health, Community-Centered Solutions, where we explore innovative community-driven approaches to health challenges. In this session, we'll hear presentations that highlight the power of collaboration, participation, and precision in creating lasting health solutions. Let's begin with an impactful exhibition spotlight, starting with a powerful photo voice exploration. Please welcome Firdos Jalgaonkar, TB Survivor Collective Mumbai, India, presenting a photo voice exploration of stigma in women with drug-resistant tuberculosis in Mumbai. Firdos, please come to the stage.
Good afternoon, everyone. My name is Firdos Jalgaonkar. I belong from Mumbai, the biggest TB spot of the country. I am also a TB survivor and also a founding member of community-based organization called TB Survivor Collective. Coming to my journey, so I was diagnosed by TB in 2016 and came to MSF in 2018 and taken the most expensive treatment, that is salvage regimen, and completed my treatment in 2020. Today, I am here to present the photo voice exploration of stigma in women living with DRTB in Mumbai. So coming to the introduction and background, DRTB remains one of the most infectious severe disease of the world. Beyond the physical suffering, stigma is one of the biggest barriers to treatment and recovery, especially for women who already face gender inequalities. To better understand this, we 9 MDR-TB survivors, including myself, participated in a photo voice project called PAR, that is Participatory Action Research, which includes photographs in which we express what stigmatization feels like and how stigmatization could heal us, advocate us, and change us for the future. So coming to the photo voice, what is photo voice? In photo voice, patients are treated as experts of their own lives. We use photographs and optional diaries to represent our feelings, experiences, and struggles. These images become our voices, creating a safe space for sharing and reflection. This process helps us not only express ourselves, but also explore the solution and advocacy strategies. Coming to the journey, like we use the method, each participant was given with a camera and asked to capture the photograph representing significant personal experiences, especially those that reflected the stigma they faced during the treatment journey. We collectively interpreted 37 images and the powerful stories behind them. Along with that, we also had the option to write diaries. We express our thoughts in our feelings in our own words. When we wrote these photos and diaries together, they created a safe space for meaningful reflection. The outcome was open and safe discussion where everyone could share freely and be heard. This process helped us move from individual experiences to collective conversations. After doing a lot of experiences and study, we find our experiences reveal 3 main forms of stigma. The first one is enacted stigma, when people discriminate against us directly. The second one is internalized stigma, when we start believing the negative things said about us. The third one is anticipated stigma, the fear of future of judgment and rejection. These forms of stigma translated into profound experiences of loss of self-identity and social voice, mobility, and social status. They also resulted in various forms of abuse, mental, emotional, and social. They cause internal distress, feelings of shame, isolation, suffocation, and even fear for our own safety. Not only this, we also build the resilience. Basically, we are from so-called society, where society always pull you down. So there are many TB survivors who build resilience too. Because the women who demonstrated extraordinary resilience through photographs, they discovered a medium to voice their struggles and support the one another and began reclaiming their agency. The process itself became a source of healing, strength, and solidarity. But we also discovered resilience, our ability to respond positively, support one another, and find strength in solidarity. From our recommendation, from our journey, we TB patients suggest, we recommend to everyone that from our journey, sharing photos and stories widely to prepare patients for what to expect, providing family counseling to reduce insensitive behavior, creating a reward system to motivate patients during their treatment, establishing peer support groups where photos can be used as tools, integrating photo voice into counseling and patient support activities. Through these steps, we can reduce stigma, build resilience, and make TB treatment journey less isolating. In conclusion, I just want to say that photo voice gave us a voice and a platform. By transforming pain into pictures and stories, we turn stigma into strength. I end my presentation by saying, I become silent, sad, and weak. Now I have to make weakness my strength. I have to open everyone once again. I have to break the chains on my own. I have to live a new life again. Therefore, I invite you all to our exhibition corner to experience the story of different forms of stigma faced by the patients affected by TB. Thank you.
Thank you, Firdaus, for sharing this deeply personal, deeply human and person-centered perspective on stigma and resilience. Be sure to visit the exhibition at the exhibit, where this powerful narrative brings to light the human side of struggle against drug-resistant TB. Now we would move to our session, and I would like to introduce our chair, Vidya Jyoti Professor Vajira Disanaika, Dean, Faculty of Medicine, University of Colombo. Professor Vajira is a distinguished medical leader and academic who's also the chairperson of the Global Genomic Medicine Collaborative, as well as the Commonwealth Center for Digital Health. With numerous national and international leadership roles and being confined the Sri Lankan National Titular Honor of Vidya Jyoti in 2019, Professor Vajira brings a wealth of expertise to this session. Please welcome on stage Professor Vajira Disanaika. Professor Vajira is very strong to take this on alone. He is joined by 4 online presenters. Dr. Shomik Maroof, ICDDRB, Dhaka, Bangladesh, and from Zimbabwe, Samuel Sithole, MSF Belgium, Mabare Adolescent Young People Health Project. I hand it over to you, sir.
Thank you very much. Good afternoon, everyone. In this session on co-creating health, community-centered healthcare delivery solutions, we have 3 presenters who are presenting online. They will present for 10 minutes each, and then at the end we will have a 15-minute Q&A with them. So let me first of all introduce the first presenter, who's going to talk to us on mapping the last mile, microsatisfaction for sustained visceral leishmaniasis elimination in Bangladesh. The presenter is Dr. Shamrock Maroof. He is a Bangladeshi physician and researcher, currently working as an assistant scientist at ICRD Bangladesh with more than 10 years experience in neglected tropical diseases. He's a chevening scholar. He holds an MSc in medical parasitology and an MPH in epidemiology. He has led or co-led over 15 studies on visceral leishmaniasis, post-Kala Azar dermal leishmaniasis, lymphatic filariasis, and DHIS2-based surveillance. He is the author of more than 20 peer-reviewed papers and an adjunct public health faculty at North-South University in Dhaka, Bangladesh. Dr. Maroof mentors emerging researchers and workers to strengthen disease elimination programs and health systems in resource-limited setting. Over to you, Dr. Maroof.
Thank you, Doctor, and good afternoon to everyone present there in person. So I'm Dr. Shomik Maroof. I'm going to present the findings from our study, which tried to map the different hotspots of the visceral leishmaniasis, but in a different approach, especially for the post-elimination phase of the visceral leishmaniasis. So the title goes as the Mapping the Last Mile, Microstratification for Sustained Visceral Leishmaniasis Elimination in Bangladesh. At first, what happened is that, as we all know, globally, visceral leishmaniasis is actually affects more than 50,000 to 90,000 people annually, with most of the cases coming from India, Bangladesh, Nepal, these three countries, and some other sub-Saharan countries from Africa. And with the elimination efforts from WHO, along with these three countries in the South Asia, Bangladesh, Nepal, and India, which started back in 2005. So it has eventually Bangladesh kind of achieved the public health elimination for the visceral leishmaniasis in 2023. So what happens now is that as the cases are going downwards, so is the funding and the efforts from different stakeholders as well. But at the same time, as we know, this is an emerging and emerging disease. So if we cannot sustain, if we do not keep continuing all the efforts we have made so far, so these success will eventually be gone, and there will be like emergence of new cases, and we cannot sustain the success. And at the same time, we have a target of achieving zero transmission by the end of 2030. So that will be also very difficult to achieve. So with all these in hand, we kind of targeted that we want to assess the spatial distribution and the shifting pattern of racial leishmaniasis at the MOSA level in Bangladesh from 2017 to 2022. Can you move to the next slide, please? Yes, thank you. To sustain the visual leishmaniasis elimination through targeted and resource-efficient surveillance and intervention. Next slide, please. So what we did, we kind of curated the data available at the MIS Department of the Directorate General of Health Services in Bangladesh, and we developed the structured questionnaire with two sections for the demographic and vector data, and one for the VL, the visual leishmaniasis, and another was for the disease diagnosis and treatment data defined through consultation with the NKP and the National Causal Elimination Program and the stakeholders. And so right now what happens, the smallest unit for any intervention for visceral leishmaniasis in Bangladesh is sub-district or upazila, but we wanted to microstratify this smallest unit to MOSA, which is the smallest administrative unit, consists of like 1 to 2 villages, we use these MOSA as a stratification unit for our study. And the MOSAs were eventually categorized as the high, moderate, low, or non-endemic MOSAs based on the reported VL cases during the study period. And we created a year-wise endemicity map and cumulative hotspot maps to actually visualize the disease burden and shifting of the endemic zones across the MOSAs. Next slide, please. So this is how we did it. So we kind of accumulated all the reports of the visual leishmaniasis cases from all these MOSAs, and if we look at the different sub-districts, we could find that about more than 495 more than 100 MOSA sub-districts were reporting cases, from where we could see there were like about more than 15,000 MOSAs are there in those 100 sub-districts. But if we kind of stratify it to the MOSA level, we will see that of those about 16,000 MOSAs, only 428 MOSAs are actually reporting cases, and the rest of the 15,500 MOSAs are not reporting any cases. So we can kind of see that if we kind of try to stratify it to the MOSA level, the total number of area comes to a very small, small area compared to the overall sub-district. And we could see that the low endemic MOSAs were 356, the moderate were 43, and high were 29. That's what we identified. Can you move to the next slide, please? And we also, after doing all this, next slide, please. Yes, thank you. So after kind of like stratifying our MOSAs into these moderate, low, high endemic areas and non-endemic areas, We found that there is a declining trend of cases, as obviously Bangladesh achieved the public health denomination, so there was a declining trend of cases. But however, there was no evidence of shifting endemicity or emergence of new foci. Next slide, please. So if you look at the maps in here, I'm not sure how much you can see it because these are very small, tiny places, all these mosaics. But I think you can see some like purplish color on the maps in the center of the map, or the northern center or central part of Bangladesh. You can see all these purple dots are kind of like clustered, and they're coming from the same area. So we can actually say that there was like no shifting pattern, or there was like no emergence of new foci, which is a good thing. And also what we found alongside these findings, that only 428 mosaics were reporting cases, which is about 3% of the total area of all the 119 sub-districts. And also we could see that the most of these cases were kind of clustered in the northern central part, which is Mymensingh, and the central part, which is Dhaka, and few in the central western part of the country, which is Rajshahi. And if you look at this map, you can see that most of the cases kind of like clustered. There's like the color marked with red, yellow, and green for the high, moderate, and low respectively. And here we can see all these large areas. If the intervention is kind of like very focused, and if we do all these interventions for the sustainment of the VL elimination, and kind of striving towards zero transmission of the visceral leishmaniasis in Bangladesh. So the effort that we have to put to actually contain these cases, or like be successful with our goals, will be much less compared to because the total number of area is way smaller than the whole sub-district of the upazilas. Next slide, please. So obviously there were some limitations, as these are the retrospective study. So the data collection was done retrospectively. So we could not get the routine entomological data. We also could not get mosa level climate data, as all the climate center data we had were kind of these centers actually covered a very large area. So picking up a small area or more like mosa was not possible within this study. And also we could not have enough information on the housing, livestock, and sleeping habits, and also the exact cost data to make an ideal assumptions. Next slide, please. So, however, despite all these limitations, we can clearly see that the study underscores the need of shifting from blanket upazila level interventions to a microstratified approach at the mosa level in the post-validation phase of VL elimination. And if we can target these smaller units, that can actually enhance our surveillance strategy. It can optimize our resource allocation, the allocated resources we have, and also can support the sustained VL control in Bangladesh. And that's how we want to actually move towards achieving the zero transmission by 2030. So that's all from me. Thank you for your patience listening. And if you have any questions, feel free to ask.
Thank you, Dr. Maharoof. That was a very, very interesting presentation. I'm sure our participants would have questions when we come to the Q&A. Let us move on to the second presentation, which is on transforming participation into power, community engagement as a catalyst for adolescent-centered health in Bare, Zimbabwe. The presenter is Samuel Sithole. Samuel is a seasoned public health professional with over 16 years of experience in health promotion, community engagement, and health system strengthening. He currently serves as the Health Promotion and Community Engagement Manager for the Bare Adolescent Health Project with Medicines Sans Frontiers in Zimbabwe. Samuel is deeply invested in community-driven methodologies and has led the implementation of patient charters, multi-channel feedback systems, and adolescent health advisory boards. He holds a Master of Public Health, an Executive MBA, and a BSc in Health Promotion, and has presented at regional platforms such as ICASA. So over to you, Samuel.
Thank you. Okay, my name is Samuel Stole. I'm the Health Promotion and Community Engagement Activity Manager for the Mbari Adolescent Health Project in Harare, Zimbabwe. I'll be sharing with you our journey in Mbari, where transforming participation into power and community engagement for adolescent-centered health in Mbari, Zimbabwe. Next slide. So I'll start by giving you or sharing with you the project context for the Mbari Adolescent Sexual and Reproductive Health Project. So the project was established in 2015, and it provides adolescents free health services, and through a peer-led model, and in 3 facilities, which are Mbari Polyclinic, Epoeth Clinic, and Matabi Clinic, and of course the surrounding communities through our community approaches. The approximate population that we serve, the population of adolescents and young people in the respective locations that we work in, is about 230,300, and this is according to the Zimbabwe Demographic and Health Survey of 2022. Adolescents in these communities are faced with high vulnerabilities, coupled with high teen pregnancies, unsafe abortions, sexual and gender-based violence, poverty, and stigma. And this is according to the UNFPA and Zimbabwe Demographic Health Survey of 2023. Mbari is overcrowded, impoverished urban area with high drug use, and this drives critical health risks for among the adolescents. Epoeth has poor housing and has high child marriages, and this exacerbates the SRH risks faced by the adolescents and young people in this community. And this is according to MSF program data of 2024. Now, these communities face barriers, which include stigma, restrictive consent laws, cost to access health services, and the weak referral system, referrals. And this is according to the Health Economics, HIV and AIDS Research Division, the head of 2020. Through programming, we've also then identified opportunities to enhance the access to services among these adolescents, young people. And this was through integrated outreach and peer-led models were seen to drive SRH knowledge by 27% and service access by 43%. And this is according to the ResearchGate of 2023. Next slide. So our objectives were to pilot this participatory adolescent, which is the patient-centered sexual and reproductive health model during the period 2023 to 2025. We intended to enhance adolescent voices in SRH governance via the Adolescents Advisory Board. We also intended to strengthen community action through capacitation of grassroots community-based organizations for sustainable adolescent sexual and reproductive health interventions, and to integrate feedback mechanisms for responsive service delivery. Next slide. So in terms of what we did, we operationalized this participatory community engagement through, firstly, the co-creation of the Patients Charter, which we co-created with stakeholders, including the vulnerable groups, the sex workers, the LGBTIQ communities, and other vulnerable groups that we serve as a project. We facilitated a participatory approach through the implementation of an adolescent advisory board to inform our interventions and to provide feedback to the project. We implemented, or we are still implementing, multi-channel feedback mechanisms through suggestion boxes in our facilities, the WhatsApp platform, SMS, the forums, which are focus group discussions with various community actors. We facilitated the formation of adolescents-led or patient group community-based organizations. And in this, we facilitated the formation and continue to capacity strengthen these CBOs. We implement patient satisfaction survey and rapid assessment to inform our interventions. We foster stakeholder engagement through community mapping and meaningful involvement of community actors. In doing all this, we sought permission from our patients, the community-based organizations, the peer volunteer educators that we work with. Next. Next slide, please. So in a nutshell, this is in a nutshell. Right there. In a nutshell, that is a diagrammatic overview of our community engagement module with the patient charter at the center and all the mechanisms and how they are feeding into each other, with an aim of fostering and sustainability beyond MSF exit. Next. Next slide. Right. So the previous slide. So in terms of the results, what we've started to see, or to notice is that community accountability and participation has been embedded fully into our project. And as a result, we've seen all the elements being part of our routine practice. We have from this started to notice an increase in trust and participation in our service delivery from the patients. We have also started to see improved responsiveness of our services to the adolescents and key population needs, enhance sustainability through community ownership, and of course, continuously embedding community voices in planning and implementation of our project strategies. Next slide, please. So, next slide, yeah, this one. So in terms of results, I'll speak about our results in terms of our strategic refocus and, of course, the program impact. From the strategic refocus, we've made deliberate inclusion of vulnerable populations in our key populations in our peer volunteer groups. We have adjusted our outreach timings to include evenings, and of course, utilizing the hotspots and the social network mapping that we've done through the community engagement. We have managed to conduct ongoing trainings for key population friendly service provision. We have also managed to support formation of key population support groups for peer connections and support for female sex workers, adolescents, young people using drugs, and the LGBTIQ communities. We have revised our teen moms strategy to address the newly identified challenges faced by the young mothers. We have also supported the formation of, we have seen the patient group CBOs providing health promotion services within their respective communities. And of course, we continuously get feedback from all these groups in the community and use that to get our advocates' priorities and to shape our interventions. In a nutshell, that's our strategic refocus. And then in terms of program impact, we've started to see the results, and this is just a snapshot of the few indicators that we've started to see. We've seen an increase in the number of adolescents reached from 7,907 to 8,481. We have seen an increase in an 18% increase in our OPD consultations. We have also seen an increase in the number of key and vulnerable populations that the project is reaching. We have also seen an increase in the number of ANC bookings that we are serving 4 times. And mental health consultations have increased by 240%. And we have started to see HIV positive treatment outcomes with low viral loads, high adherence, low default rates, and linked 38 clients to care. Next slide. Lessons learned. So we have learned that structured community engagement builds resilience and urgents crucial in crises like donor funding withdrawal. Peer-led CBO sustains services beyond donor shifts. Shared decision-making strengthens trust and co-created solutions. Community-driven approaches mitigate shocks by leveraging on local capacities and ownership. Community engagement supports transition to sustainable adaptive community health systems. Next slide. In conclusion, we have seen that community engagement strengthens resilience, it shifts power to adolescents who are the patients and peers and communities. There is proven impact to this. It sustains health or SRI services during shocks like donor funding withdrawals, like the recent withdrawal that we've witnessed of the USID. Next, we aim to expand participatory community engagement models and integrate advanced community-driven health solutions to strengthen adolescents or patient-responsive care, internally within MSF. Take-home information or take-home message from this that empowered communities is equal to resilient health or SRI systems. Next slide. Acknowledgements. I wish to thank the adolescents that we work with, advisory board, volunteer educators in the community-based organizations, MSF Mbari project team, Ministry of Health and Child Care, Zimbabwe, and ECO's local board. At large, I would like to send my sincere acknowledgements to the FOCB for supporting this project. Thank you.
Thank you very much for that very interesting presentation. Let's move on to the third one. Invisible No More, unveiling the overlapping risks of drug use and HIV in Indian prisons. The presenter is Sudarshan Kandaswamy. Sudarshan is a M&E specialist with over 12 years of experience in public health, focusing on HIV, TB, and community system strengthening. He excels in data-driven insights, strategic frameworks, and stakeholder engagement, delivering impactful solutions for global health initiatives. Over to you, Sudarshan.
Sudarshan, you're on mute. No, we still can't hear you.
Yes.
Maybe take out your earphone and just use the computer speakers.
Okay, am I audible now?
Yes.
Yes. Yeah.
Okay, so good afternoon everyone, and then good afternoon to the distinguished member on the dais and respected organizers and all participants. I'm Sudarshan Kandaswamy, and it's my privilege to present on Invisible No More and Healing the Overlapping Risk of Drug Use and HIV with Indian prisons. Prisons are often overlooked in public health, yet they carry a high burden of drug use and HIV. Today I will share the insights on those overlapping risks and why addressing them is urgent and essential. Next slide. Okay, so this is a little bit background. People who use injecting drug in India is nearly like 2,88,717, and then HIV prevalence among PWID is like 9.3%. And then globally, HIV prevalence in prison is like 5 to 7 times higher than the general populations. As per the Indian context and as per the Sentinel Surveillance 2021, the HIV has been identified 1.93% inside the prison, and hepatitis B is 1.89%, and hepatitis C is 4.75%. HIV hepatitis co-infection is 0.15, and HIV hepatitis C is 1.07%. Next. So 9 out of 10 HIV prison inmates who inject drug know their status only after entering the prisons. So this is how like our project has been like introduced over there. Our project name is Sashakti, and then we were having an initiative of addressing the HIV and AIDS through integrated care, innovative approach and community empowerment. And then our mission is to contribute the India's national target of 95, 95, 95 for HIV and ending the TB by 2025. Implemented across these interventions in 19 states, but prison intervention is in 15 states of India. Under the prison and close setting, a focused approach to address health challenges in 15 states. So we have 597 prisons and 146 closed settings. And then we are having an approach of like a targeted screening and holistic care, regular HIV, STI, TB, and hepatitis testing for inmates and residents, and ensuring the timely linkages to the treatment facilities for the inmates. Strategic partnerships, we are working with the state authorities to improve the health outcomes in the marginalized settings. Next slide. So the methodology which we have adopted is, it's a cross-sectional analysis of like 1,320 drug users, drug using inmates from the 15 states, and then the structured questionnaire integrated into the M&E framework as a routine data collections, variable considered for analysis for socio-demographic, sexual practice and HIV status. And then we have used a descriptive statistics in association by using the SPSS 20.4 and considered the significance of p-value of less than 0.05. Next, please. So this is related to the inmates profile. So like the majority of the inmates are from the 18 to 20 years, and then 31 to, and then with the following age groups are like gradually getting decreased. And then the education profile, if you see 45% are above like secondary educations and above. And then the employment status, like self-employed is the kind of like 40%, and full part-time employees has been contributing as a 32%. But among this employee status, almost like 50% either are the seller of the drugs or drug peddlers or the dealer of the drugs. Next. So this is the drug use patterns. 20.5% reported the injecting drug use identified as a HIV positive from the total registration. And then HIV positivity is significantly higher among the one who used the drug and then was compared with the kind of the one who's not using the drug. And then it is a kind of like having association, and then it is significant like when it is a 0.05. And then the 89% of HIV positive injecting drug users diagnosed during the kind of incarceration. Next. This is the kind of like related to the sexual risk practice. So 28% to 37% reported unprotected sex among the partners, and then HIV positive 70% among low condom users, and then 6.7% PWID with the transactional sex history. Among them, 61% of them are identified as a HIV positive, and then 5.4% injecting drug users had a sex with same sex. Among them, 76% of them are identified as a HIV positive. As per the HSS also proven that like 55.2% of inmates having sex inside the kind of prisons. And then if you see, this is the kind of like graph used to illustrate as condom use among the different type of partners. And then majority, they are not using a kind of like condom at all with any kind of partners. So only like very few inmates are like having a kind of exposure to use the kind of condoms. Next. This is intersection of the risk. So the drug use plus unsafe sex is equal to the kind of like compounding the vulnerabilities. It is increasing the vulnerabilities, and then the stigma and lack of harm reductions like worsen the risk. And then the similar patterns has been seen globally but rarely documented in India. In India, the major problem is condom promotion is not allowed inside the prisons. Next. So the recommendation which I used to suggest is like expand the harm reductions OST, which is called as opioid substitution therapy, and then integrate the kind of sexual health education in prison settings, awareness on the condom use, not promoting the condoms because as per the guidelines it is not acceptable, and then dedicated persons at the prison for the counseling, address the stigma and improve the healthcare access, routine screening and linkages of care for all inmates. As a kind of like closing remarks, every year thousands of inmates return to the communities. Addressing the HIV HIV in prison protects the public health Investing here reduces the overall HIV burden in society. Thank you.
Thank you very much. So we had 3 very interesting presentations. May I open the forum for questions? Anyone who would like to ask questions from our panelists? While everybody gathers their thoughts, can I come to the second presenter? I very much like the work that you're doing, because it, I think, spoke very clearly and straight to the theme of this symposium, which is co-creating health. I was interested about your, Samuel, I was interested about your charter. How did you develop it, and how do you really use it in practice? In our country, just the reason why I asked that question is we developed a charter for patients' welfare and well-being and patient safety, and got it adopted by Parliament, and that's where it stands in terms of implementation. So here is a local initiative that you have done, and I'd very much like to see how you kind of implemented, how you developed it and how you implemented it. Over to you, Sam.
Oh, so thank you for this question. The patient charter co-creation was informed by MSF Scientific. And then we went on to consult the patient itself, looking at various targeted projects for key and vulnerable populations, consulted them for them to how the patients can.
Samuel, you are breaking up. We can't hear you clearly.
Can you hear me?
Yes, now better.
Okay. So to start with, I think the patient charter creation was informed by the MSF Scientific Days. And so we took these standards to the patients, we consulted them, give their inputs as to how it arrived, is respected, and we put all these things together and came up with the patient chart. We then took back to them to see if all their issues or all their points that were present. And from there, we like the patient's charter. How to implement it? We implemented it mechanisms where we said how we want to fit any of these rights or wish to done by the project has not been done. And they gave us feedback in terms of how they want to feedback the patient project, how to issues to and then from there we constantly engage with them with instance of community that we send on patient starter, of course on feedback mechanisms that are available for them to give their feedback to and as a team sit down as a project to see how we can best get
Samuel, I'm sorry, you're cutting off. Maybe if you can type it in the chat, that would be great.
Yes,
Thanks.
you can probably type that answer in the chat, and everybody will see it. But I'd like to, for the benefit of the audience, pose a question at our MSF colleagues here. I believe that this charter aligns with Medicine Sans Frontiers quality standards. So perhaps our members in the audience have not heard about these quality standards. Is there anyone from our Medicine Sans Frontiers group who are able to explain what these quality standards are, because that will be so very important for our audience to know what they are.
Yeah. The patient charter is basically about the roles and responsibilities of the healthcare workers towards the patients. And in MSF, especially in MSF OCA and other sections, it has been implemented. In some sections not, but across MSF we are in this mode of implementing it and making sure that the patients are clear about the roles and responsibilities of healthcare workers. However, the responsibilities of the patients are also clear. And how this interacts with quality standards is we want to make sure all our patients and our communities, they receive safe, timely, person-centered, efficient, effective care. And to be able to monitor that they are receiving, there is also patient feedback and community feedback mechanisms in place. And the patient charter would only work if these mechanisms were in place, that they could report back on how things are going for them. We are far from doing really good on this. Community feedback mechanisms and patient charter is still something we are working on in MSF.
Okay, thank you. I think when it comes to these charters, everyone always, it's a work in progress. Susie, I think I was just thinking, if there are these standards, we can look at the charter that we developed for Sri Lanka against these standards and see whether there's anything that we have done which is, does not meet up to some of those indicators, as well as we may have done, may have captured other things that are not there, and so you can, I think, learn from each other. Yes, thank you very much, and thank you to Samuel for having taken the initiative to develop the charter and implement it to engage with your community. Over to the audience. Any questions to the panelists? Yeah? Anyone? Any online questions? No? We don't have any? Yes? Okay. So in the absence of questions, then shall we wind up this session? Thank you very much. Let's show our appreciation to the panelists in the usual way. Thank you.
Thank you, Dr. Professor Vajira and all our presenters for their thought-provoking contributions to today's sessions. As we wrap up, let's take these powerful community-centered solutions, microstratification, participatory community engagement, refocus based on community feedback, HIV/TB care in prisons in India through integrated approaches. Take them with us and continue working towards a more inclusive and resilient health systems. Prior to this event, a friend of mine asked me not to crack jokes as this was a serious event. Well, they were not aware that we have a counselor amidst us. In this session, session 4, Beyond Pills, Advancing Quality Care, we focus on innovative approaches to delivering high-quality, compassionate care beyond traditional treatments. Here, we will explore diverse perspectives on improving care in challenging environments, from humor therapy in hospitals to addressing the political dimensions of health. Let's begin with an exhibition spotlight on the power of humor in healthcare. Please welcome Sheetal Agarwal, counselor from Mumbai, presenting Healing Through Humor, Evaluating the Impact of Medical Clowning on Patient Well-being in Indian Public Hospitals. Sheetal, please join us on the stage.
As I entered the hospital, in the corridor there was a child in the lap of a mother crying profusely. And the moment she saw me, she jumped out of her lap and held my hand and started guiding me to her bed in the oncology ward of Apollo Hospital, Delhi. We started playing. She was engaging with my puppet. I was doing silly things and she was laughing uncontrollably. When her mother shared that since morning she has been crying, she didn't let me sit, She did not sit, she hasn't eaten since morning, and the moment she saw you, she got so happy that she jumped out, and now she has forgotten all about her pain. Good afternoon, I'm Sheetal Agarwal, talking about healing with humor. We've all heard laughter is the best medicine. How many of us practice it? What really is the problem? When we talk about health, it is healthcare in total, and it is made of both physical and mental health, while at healthcare facilities we see that a lot is being done for their physical health, but there is very little that is done for emotional and mental health. We try to bridge this gap through medical clowning. What really is medical clowning? It is a therapy which was started by Dr. Hunter Dorothy Patch Adams. He was studying medicine when he saw that patients are agitated, frustrated, stressed, and he started using medical equipments as props to cheer patients up. He would do silly things, and he saw the recovery rate is getting better, how patients were responding to medication changed, and that's how medical clowning came into being. Though it has been there since 1970s, it is not as popular in India, or most people that I met from Sri Lanka have not even heard of medical clowning. So that's where the gap is, and we are trying to bridge this gap by introducing this to different hospitals. And how we do it? We dress up as clowns, not those outlandish costumes, but just simple wigs and noses, and it differs culturally. So when we go to Europe, they don't wear the wig. In India, the wigs work better. We have tried different things. And we use songs, dance, humor, activities, everything that can make people smile. Sometimes it's also just holding space. Sometimes parents start crying on our shoulders. We hold that space for them so that they can vent out and feel better. This counselors came into being by accident. It was not a planned professional effort. We started with 5 volunteers, and we stepped into the hospital with dinosaurs running in our stomach because the trainer did not end up before we started. And when we started clowning, we saw the atmosphere change. We heard parents say, our child has laughed after 7 days. Our child has eaten after 10 days. And many such things. And after 5 hours of clowning at a public hospital, when we came out, we couldn't stop smiling. It's a two-way healing process. The healers also heal themselves. Over last 9 years, we have touched more than 8 lakh lives, not just in hospitals, old age homes, refugee camps, conflict zones. Even we have started working with the Indian Army and at the workplaces. The idea is that humor can be introduced to spread awareness on mental health. Now, again going back to, how many of you have heard laughter is the best medicine? Show of hands, please. We all know the benefits, right? That it helps relieve pain, it boosts immunity, it helps in the oxygenation process. If in COVID we were laughing a little more, maybe there would have been little less deaths. And it is proven by scientific research, it's not me speaking. What we have seen is that in the hospital that we started clowning back in 2016, it was observed that doses of anesthesia are reduced pre-operation for children who are exposed to clowning versus those who are not exposed. In pediatric dentistry, it was found that stress and anxiety goes way down when children are exposed to clowns while the treatment is on. Also, when we went to TB wards in Mumbai, doctors came back and said that this is the first time that patients did not come with a grumpy face. They were more communicative and they engaged better with us today. It was helpful for even doctors to connect with the patient that day. In oncology and palliative care, especially when we talk about terminal illness, people start waiting to die. And when clowns come, it kind of gives them hope, and they say that this was the highlight of their day. I invite everybody to join us in our mission of ensuring that doses of laughter is given equal importance as doses of medicine. And with that, I also invite you to please stand. You've been sitting all day listening to people and listening to me now. Let's do an activity together. Can I get a mic? Or it's okay. Can you all see me? Yes. Okay? And you have to do as I do, say as I say. Yes? Can't hear you. Everyone, yes? Let's start with shaking our hands. Shake, 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 shake with a smile. Shake, shake. Bolna bhi. Say it also. Shake, 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 shake. Shake your legs and shake your bums. Shake, shake, shake. You have to keep saying shake, 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 shake. And shake your head. Backbenchers. Shake, 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 shake. And shake your tongue now. You have to do it. You can't just laugh at me. Okay, this was just a warm-up. Now this is do as I do, say as I say. Do you all believe you are stars of your lives? Yes? The louder you are, I would believe that you are the stars of your life. Okay? I'm a star. I'm a big star. Out of you only I am a star. Come on everyone. I'm a star. I'm a big star. I'm a small star. You can move your hands. I'm a rock star. I'm a superstar. I'm a star. I'm a star. I'm a star. I'm a star. Thank you so much. Thank you. Also, we have an exhibition outside. If you have any questions or if you want to know more or collaborate with us, please do visit us. Thank you.
Thank you, Sheetal, for reminding us about the healing power of humor. It's important that we are reminded once in a while. Now let me introduce the chair for the session, Dr. Susie Pereira, Senior Public Health Professional and former Deputy Director General, Ministry of Health, Sri Lanka. She's been a transformative leader in public health policy development, particularly in areas such as universal health coverage, primary health care, and non-communicable disease management. With her extensive experience, including her leadership as the former Deputy Director General of Public Health Services in Sri Lanka and Vice President of the Sri Lanka Medical Association, as well as being a former senior consultant for the World Health Organization, Dr. Pereira has been instrumental in shaping national health policies and initiatives. We are privileged to have her guide us through this session today. Please join me in welcoming Dr. Susie Pereira. I would also like to invite the presenters on stage. Safrina Farhat Manzil from OP Jindal Global University, India. Dr. Joseph Kanat, Maulana Azad Medical College, New Delhi, India. Additionally, we are joined online by Abdul Mulazada from MSF. And we'll also be featuring a video exhibition spotlight from Rachel Yanzi of MSF Barcelona. Over to you, ma'am.
So welcome to the session, I think just before the closing remarks, and I'm sure we've had an interesting time today. And I hope after all that clowning, let's try to still make it interesting, right? So, pills. That's what we know when we come to medical care. All we think of is medicines. But there is more, and that is, I mean, it's really good to see this session pulling together the other side. Not the pills. What can care be? Right? So we have some interesting presenters and probably another exciting exhibition also. Let's hear about the quality of care in fragile, conflict-affected settings, and analysis of quality of care delivery into hospitals in Yemen. And I will introduce the presenter, who is Dr. Abdul Wasem Mullahadda, who is an experienced public health professional with over 20 years of experience with MSF. He currently works as the public health coordinator, health advisor for MSF programs in Syria and Yemen, and pursues his PhD at, I don't think I can pronounce this, Vrije University, Amsterdam, right? Okay. Focusing on quality of care and patient safety in fragile and conflict-affected settings. He has extensive field experience across Yemen, Iraq, South Sudan, Syria, Papua New Guinea, Uzbekistan and Tajikistan, Australia and Pakistan. His work is rooted in improving healthcare delivery in humanitarian settings, ensuring high standards of care in the most challenging environments. So this is what is important, is even in the most challenging situations, there is something about quality that is being taken care of, and we strive to improve it. Over to you, Dr. Abdul Wasem.
Hello and good afternoon. Can you hear me? Hello?
We can hear you, Dr. Abdul.
Afternoon. Thanks, Madam, for the introduction, and it's my pleasure to present the result of our analysis on the quality of care delivered in 2 hospitals, MSF-supported hospitals in Yemen, on behalf of our study team. These 2 hospitals were also divided by a front line on the both sides of the same governorate. I'm also particularly pleased that this presentation is also coincide with the World Patient Safety Day and also the theme of today. So far, since morning, we are hearing a lot about patient safety and quality of care. A reminder that advancing quality of care is as urgent in fragile and conflict-affected setting as anywhere else. Next, please. We all know why quality of care matters in fragile settings, like Yemen. Poor quality of care causes between 5 to 8 million deaths every year, particularly in low and middle income countries. In settings like Yemen, added complexity, fragmented health system, workforce shortages, overwhelming workload, and the scarce resources that makes sustaining and monitoring quality of care even harder. We usually hear quality versus quantity discussions and dilemmas in fragile and humanitarian settings. Yet this is exactly where quality improvement and safe care must be prioritized and most needed because of all vulnerabilities that the population and the health system are facing. Next, please. We asked ourselves in the organization, but also in these 2 hospitals, what is the quality of care provided, looking at structural processes and outcome indicators across these 2 hospitals, which was providing care for largely mother and child health, and how these 2 hospitals differ, if any, with the aim to understand the differences so that we can identify actionable areas for quality improvement. Next, please. What we did, this slide's a little bit dense, is that we triangulated quantitative design combining routine program data with survey findings to capture a more holistic view of quality of care provided at that particular moment. Assessing quality of care across the WHO 7 dimensions of through Dunobedian model, which is quite a well-known model in assessing and monitoring quality of care in the health sector. From over 10,000 variables and indicators that are in the routine program reporting system of MSF, initially we selected 250 indicators, and then after the literature review with high impact indicators, and also looking at the quality of the reporting, and in consultation with the specialist, we reduced it to 117 with the aim following this logic of is 100 indicator or 117 indicator better or enough or not. Next, please. Here you can see in this result, the table summarizes from the retrospective data analysis that we did between 2019 and 2022. The performance indicator in both hospitals shows that Rais Hoban performed consistently better compared to Al Jamhuri Hospital in most of the WHO dimensions, particularly effective care, timely care, safe care, person-centered or patient-centered care. While Al Jamhuri Hospital also performed better in efficient and equitable care. Both hospitals showed gaps, though some improvement over time was noticed in reporting and meeting some of the benchmark. Missing data, you can see, is NA, non-availability. Missing data inconsistency in reporting was improved over time, but yet a major gap and challenge in routine reporting. The documentation is though improving, but what was the main challenge we see over time? Next, please. If we look at one of the dimensions in safe care, looking at the safe care, we see that important gaps identified. If I don't know if one or two more clicks can be done. There are 2-3 other points circled, if possible, to click, please. Yeah. So we can see that that there is medical incident reporting is weak, and staff training on patient safety culture almost not reported. I would not say not exist. While the WHO safe surgical checklist was widely used, morbidity and mortality reviews were really limited, especially in Al Jamhuri Hospital, comparing the benchmark set by the hospital. Other elements such as patient identification, medication safety processes are not measured or not reported, which shows blind spots in critical care and critical areas. Next, please. Now it's highlighted. When we look at the outcome section of the same safe care domains, medical incident reporting and management being a key learning and safe culture indicator. Both hospitals are underreporting and a lot to be improved. Although we see that these are the circles that you can see that are not reported. A lot to see on the outcome of safe care. Next slide, please. We also see that in a patient-centered domain, or person-centered, we call it in the MSF, we see some strong points, but both hospitals have patient consent policies in place, active complaint system is in place. It might come in the when the clicks are happening, there are circles. And routine health promotion are provided. Patient satisfactions, if you look at them consistently, high in both hospitals, 90%. Key elements are missing in Al Jamhuri Hospital, like space for caregivers was a gap, and also both hospitals lacks culturally adopted end-of-life or palliative care, which was mentioned in the last session as well, was missing. Feedback processes are inconsistent, in patient involvement with discharge planning was also not reported, at least in the data it shows absent. This shows that while patient satisfaction with direct interaction is good. Structural element for meaningful engagement and culturally appropriate care remains weak, and much to be done and attention to be given by both hospitals. Next slide, please. Next slide, please. Yeah. The survey, as I was saying at the methodology section as well, from over 350 respondents across staff and patients, we were surprisingly high satisfaction rate from patients, 94% in Thai Soban and 88% at Al Jamhuri Hospital reported positive experience, though non-clinical staff are slightly lower and the satisfaction rate, and this, they were showing in the rest of the analysis that they were not involved and they did not see themselves as part of team to improve quality of care. We have also used the 4-point Likert score scaling, meaning the lower the scale is, the better the satisfaction is. Next slide, please. We also look at each category of staff who participated in the study. So clinical staff, they basically said the clinical staff, both hospitals, recognize their role. However, clinical staff at the Jamhuri Hospital expressed frustration at system level. Limitation despite good intention and understanding of their role in quality care provision. They lack the environment, the leadership support, and the time to consistently deliver and maintain quality care. Though if you look at the slide, Thai Soban Hospital felt more empowered compared to Al Jamhuri Hospital, but both hospitals had the same gaps identified from the medical staff. Next slide, please. In non-medical staff, same, especially cleaners, registrar, wards and facility management staff in some of the health system, they call them laboratory team, supply team, we call them operations, and supporting department. They felt excluded from quality improvement efforts in these two facilities. These matters a lot because infection prevention control, safe culture, patient flow, welcoming and safe environment, this hospital, cleanliness, but also motivation of these supporting department staff are key in maintaining and sustaining quality improvement. Next, please. Patients and caretaker in both hospitals expressed, as you can see, high satisfaction with the care they experience. While this is clearly an encouraging figures and result to see, it also underscores the risk of overestimating quality based on perception alone, without triangulating it with the objective performance indicators, which is the structure, processes, and outcome that we have looked at it during the study. Next slide, please. What we did with this finding, we triangulate the objective indicator with the staff and patient feedback that comes out of this survey, the result, but also the regular cycle that was put in place. We invest in creating a shared vision for quality and quality of care improvement priorities across the management, leadership of the hospital, and frontline workers, the department level, and so linked with the feedback that was regularly collected from patients and caretakers. We also simplified monitoring system, too many indicators, too many silos of reporting in terms of, with the good intention to improve quality, was creating confusion and not improvement. Reinforce the governance
Dr.
structure.
Abdul, you have just 1 minute more. I think you have exceeded your time.
I'm the last slide, just one slide. Next, please. In conclusion, what we saw is the quality of care as a bit of a key message or takeaway. I would say the rest of the slide you can see. Quality of care is feasible and sustaining in quality improvement is achievable even in fragile contexts like Yemen. Perceived quality depends on experience, not structure, but it's sustaining it requires engaged staff, consistently monitoring and closing the loop, a leadership that listens and promotes safe and quality care and efforts around that. And finally, less data is better than a lot of data and too much reporting without actioning on them. Next slide, please. Limitations similar to several other mentioned. So some of the indicators were arbitrarily selected. You know, somebody can ask why 117 indicators. And the hospital data from Thai Al Jamhuri Hospital was only for 2 years. As we all know, with cross-sectional surveys, they can't capture the trend. But this mixed method, we think, was solid enough to give us a good learning on the way forward. Last slide, please. I would like to acknowledge and thanks all the study team, the both hospital and the rest of the team who were involved in these processes, particularly patient and caretaker and the frontline staff for both hospital who participated in this study. Thanks.
Thank you very much, Dr. Abdul. Yes, quality has to be felt, it has to be assessed, and it has to be communicated. Even though it is in two institutions, it is important, and I think the efforts are magnificent, that these the indicators are being identified and they are being tested. That is really a good move. I would like to introduce the next speaker, Dr. Safrina Farad. Right? Okay, that's okay. Yeah. She's going to speak on intersection of political determinants of health and community participation, a case study of public health model of palliative care. She holds a master's in public health and human development with a specialization in health systems and policy from O.P. Jindal Global University. She works in monitoring and evaluation consultancy with a focus on community-based health programs. Her research interests include political determinants of health, community participation, and gender. A passionate advocate for social inclusion, disability rights, and palliative care, her dedication is deeply shaped by her lived experience as the mother of a specially abled child. She also volunteers at the Institute of Palliative Medicine. Okay. Over to you, Farah.
Good afternoon, everyone. I'm Safrina. First of all, I'm thanking the organizers for having me here. Here I am presenting a case study which explores the intersection of political determinants of health and community participation in public health model of palliative care in Kerala. This presentation is based on my master's thesis guided by Professor Nandita Pan and Sambuddha Chaudhary. So, introduction parts. As we all know, palliative care has evolved from end-of-life care to a comprehensive approach which addresses physical, psychosocial, and spiritual needs. It also improves the quality of life of patients and family, and it also ensures the autonomy and dignity of the patients. So the access to palliative care has recognized as the human rights. WHO recognizes as the rising need of the non-communicable diseases and aging population. The access to palliative care is very urgent than ever. However, the access is still limited. The data shows that only 14% are accessing globally, whereas in India, 6.21 per 1,000 people are accessing. But in Kerala, says a different story. In 1993, institution-based palliative care started. In 1999, community-based palliative care was started by the community-based neighborhood network palliative care. The name was the community participation. So, in 2008, palliative care policy implemented in Kerala. Kerala is the first in Asia which implemented the palliative care. The main features of the policy is it's a bottom-up approach, decentralization of care, and right-based approach. Main principles of the palliative care policy: community participation as a core principle. It's integrated with the health system. Home-based care is emphasized, and capacity building and access to essential medicine. This is the public health model of palliative care. Based on this policy, public health model started. There are three stakeholders in collaborate. There is a collaboration between the local self-governing institution, primary healthcare centers, community-based organization. The objective of the LSJ is resource allocations and governance, the PHC for clinical expertise, and CBO for grassroots knowledge and volunteer for psychosocial support. This model is a blueprint for low and middle income countries. So let us go through the political determinants of health. Political determinants of health refers to how power, policies, and resource distribution shape health outcomes. This is the definition of political determinants by Davis. According to this, the political determinants operate through structured relationships and governance systems that either promote health equity or deepen the disparities. In the context of palliative care in Kerala, understanding these dynamics is essential to ensure fair and effective service delivery. Aim of the study is how community participation influences the palliative care policy implementation, and how political determinants of health such as resource allocation, power dynamics influence the effectiveness of the collaboration. This is the methodology. It's a qualitative case study. My study site was Kodyathur Panchayat Palliative Care Unit. The study participants are the stakeholders of the collaboration, representatives from the PHC, LSCA and CBOs, healthcare providers, patients and family, and policy makers. The data collection show the interview guide and analysis using thematic analysis, got the ethical approval from JSPH. The findings reveals a complex but effective ecosystem. Positive patient experience. Patients received regular home visit, essential medicines, food kits, and psychosocial support. This holistic approach improved their dignity and comfort. Caregivers' role. Caregivers were central to decision-making and care coordination. Their empowerment through training and community support was vital. Community participation. CBOs played a crucial role by providing flexible funding, manpower, and rapid response capabilities. Their grassroots presence made care more responsive. Political determinants, a policy framework and resource distribution shaped care delivery. However, power dynamics, especially between the medical officers and LSCA representatives, led to conflict, ego clashes. Resource allocation. LSCA's annual budget of 12 lakhs was often insufficient. CBOs stepped in to fill urgent gaps, demonstrating the importance of flexible, community-driven funding. Collaboration. When LSCA planning aligned with the CBOs and PHC resources, patient outcomes improved significantly. This synergy was key to equity and sustainability. Service delivery. The quality of care depended on how well stakeholders collaborated. Equity, responsiveness, and long-term sustainability were directly linked to this coordination. The Kerala model offers several insights. Community participation, it enhances access, ensures sustainability, and centers care around patients' needs. CBO's role, their limited political influence allows them to be more agile and responsive. Barriers, resource gaps, bureaucratic delays, and power struggles hinder service delivery. Challenges, power dynamics, and inequitable resource allocation can undermine the collaboration. Collaboration benefits. Joint efforts between the LSCA, CBOs, and PHC improved care delivery and crisis response. Communication strengthened coordination among stakeholders led to better planning and execution. Compassion-driven care. The model prioritizes the compassion and community needs over political agendas, making it truly patient-centered. There are some limitations for my study because time constraint was the main limitation. I have got only 2 months to do this. So this restricted the breadth of the study. Some participants were hesitant to discuss challenges leading to potential positive biases. Existing relationship among stakeholders may have influenced their responses, affecting the objectivity. These are the recommendations. To strengthen the palliative care delivery, formalize collaboration for coordinated and equitable services, increase budget flexibility to address urgent needs, build capacity in psychosocial care and teamwork, strengthen policy support and advocacy to ensure the sustainable funding and promote community-driven models, ensuring equity and transparency in resource allocation through need-based prioritization, promoting community participation and volunteer engagement to sustain compassionate care, establishing robust monitoring and evaluation system to ensure accountability and continuous improvement. So, Kerala model demonstrates the community participation and political determinants are crucial for equitable palliative care delivery. Effective collaboration among LSCA, CBO, and PHC are ensure responsive and sustainable service delivery. Health is inherently political. Governance, policy, community must work together to shape better outcomes, and compassion sustains the care. I would like to thank my study participants and my mentor, Dr. Suresh Kumar at Institute of Palliative Medicine, and Dr. Devi Vijay. Those who support this for my study, and last but least, my professors at Jindal School of Public Health and Human Development. Thank you.
Thank you very much for keeping to time also. And it's interesting to note that the political inclinations are really for community-based organizations to be more involved in palliative care. So that's very interesting because I believe the Kerala state does have formalized mechanisms of engaging community-based organizations. I'm sure the audience may have more questions to ask. I think next we have an interesting presentation by Rachel Yancey. And that is, we need to put ourselves in others' place to understand. So she has framed it, I have to put myself in their place, exploring empathy in humanitarian palliative care through the stories from Cox's Bazar, Bangladesh. So we are talking about more and more into the quality aspects, the compassionate aspects, the person-centered aspects of care. And let's watch this. Yeah. Maybe I should introduce...
My name is Rachel Yancey. I'm a pediatric palliative care nurse, and I'm the mobile support technician for...
Can I introduce? Yes, I missed introducing. So Rachel Yancey is a mobile support technician for pediatric palliative care for MSF, OCBA. She is a pediatric nurse and PhD candidate in health research methodology at McMaster University. She holds a master's degree in community health nursing and public health from the University of Illinois at Chicago. Prior to beginning her role as MST that is mobile support technician, Rachel completed 2 assignments with MSF as nursing activities manager in the Central African Republic in 2009 and in Cox's Bazar, Bangladesh from 2020 to 2021. Her research is focused on healthcare workers, moral experiences, and the ethical aspects of integrating palliative care in humanitarian response. Let's view this.
Hello, my name is Rachel Yancey. I'm a pediatric palliative care nurse, and I'm the mobile support technician for pediatric palliative care for MSF Spain. Within MSF, we're talking more and more about the importance of empathy and person-centered care, and we're trying to do a better job of treating our patients as people rather than just as a diagnosis. However, the word empathy has become a bit of a buzzword. What does it actually mean to treat our patients with empathy? Our exhibit focused on empathy in humanitarian palliative care here at MSF Scientific Days explores this question. The exhibit is based on a qualitative study that was conducted at the MSF Goilamara Mother-Child Hospital in Cox's Bazar, Bangladesh in 2021. The aim of the study was to explore MSF staff's moral experiences of providing pediatric palliative care. The study used a methodology called ethnography, and data collection methods included participant observation, individual interviews, and focus group discussions with a variety of staff who provide care for children and babies with serious illness or who are at end of life. During the data analysis process, we noticed that staff talked a lot about the importance of empathy, and even staff who spoke limited English used the English word empathy quite a lot. MSF staff understood empathy to involve being emotionally responsive, trying to understand other people's experience, as well as specific ways of speaking and acting that demonstrated empathy, such as the tone of voice and perhaps holding someone's hand. Unfortunately, in the context where MSF operates, empathy is not always easy. Based on the findings, we have developed 3 short stories that explore the meaning of empathy to international and locally hired MSF staff and their moral experiences of trying to provide empathetic palliative care. The stories focus on the emotional connection staff have with their patients and families, the difficulties staff face to relate to certain people's experience, and their fears of becoming desensitized to the suffering that they see all around them. If you visit our exhibit, you'll have a chance to read one of the stories and listen to audio recordings of the others in English or in Bangla. You will also have the chance to reflect on what the stories can teach us about the importance and challenges to empathy in humanitarian contexts and what needs to change to encourage a culture of empathy within MSF. We have a space for you to share your thoughts using Post-it notes, or you can use an electronic QR code to share your ideas with us. The stories are meant to promote reflection and discussion, so we would love for you to join us at the exhibit. I would also like to express my sincere gratitude to the staff at Goilamara Hospital for your willingness to share your stories and for your ongoing commitment to accompany children and their families through incredibly difficult moments. Thank you, and we hope to see you at the exhibit.
So we have these the exhibits on display outside, and also the clowning one also. That's interesting. So is this one. You need to go and observe this. You would be really enlightened about how empathy and what empathy can really do in make the difference, even in a difficult situation. Right? So our next presenter is Dr. Joseph Lazar Khanna, who is a preventive medicine physician currently pursuing his master's degree at Delhi University in India. He has a strong interest in public health research focusing on health economics, health-related quality of life, and cancer care. He is committed to evidence-based policymaking and aims to improve healthcare delivery in resource-limited settings. His research has been presented at both national and international forums, demonstrating his dedication to advancing population health outcomes through scientific inquiry and collaboration. He's going to talk about health-related quality of life among patients with cancer in a public hospital in India, a cross-sectional study. Over to you.
Good afternoon, everyone. First of all, thank you, Dr. Susi, for the warm and elaborate introduction. So I'm going to be short and quick because it's a post-lunch session. So the topic, already she has given an introduction, so I'll go to my second slide. So what is health-related quality of life? So health-related quality of life is a multidimensional concept which helps us assess the patient's health status, how it affects the overall well-being. So how the health status is affecting the overall well-being. That's it. So why do we need to do it? We need to do it to see how the patient is doing, how his treatment outcome is, how a patient is responding to our treatment, is he happy, how is his overall well-being, and so on. And as researchers, it helps us conduct STA also, that is health technology assessments. So why did my team decide to go ahead with this? So we all, Safrina already talked about Kerala, how palliative care has grown and how it has taken over the state in a community form. But Kerala is a state in south. There's a stark contrast between south and north when it comes to palliative care, and there is no data that comes out of the north. And the college that I'm doing my post-graduation right now is in Delhi, that's in the north of India. So that's why we decided to go ahead with the study. So coming to my material methodologies, so it was a cross-sectional study that the title only suggested. I had around 200 participants, and the questionnaire that I used helped collect data on demographics as well as quality of life. So the demographics, I only pre-designed the questionnaire, but the quality of life, I chose a Eurocall. The Eurocall is an organization, a European organization, which has already developed a tool, especially for India as well as Southeast Asian country. It has been validated in India, especially in Hindi, that is the co-official language of India. So that's what I used. The tool, exactly what I used is EQ5D5L. So I'll talk little about the tool. So it's EQ5D5L. Look at the 5D. It's 5 dimensions of overall well-being. So it has mobility, pain management, anxiety, self-care, and daily activities. These are the 5 dimensions. And each dimension will be given a number according to the response given by the patient. The participant can give around 5 responses, like from 1 to 5, 1 being the best and 5 being the worst. Imagine I'm taking pain, so there is no pain, that will be 1. And the pain is not managed to any extent, that is 5. So from that we can get around 3125 health profiles, that's doing all the permutations and combinations, all the math heads out there can do it. So imagine we are getting a health profile that is quintuple ones, that is all the 5s. All the numbers are ones. That will be the best health profile that we have, and the quintuple 5s, that is the worst health profile that we can have, the worst health profile that a patient can have. So these are the health profiles, and from that we can actually calculate the utility score. How do you calculate the utility score? So Eurocall has actually developed a value set for each tool that they have developed. All the validated tools that I have developed. It's given in their website, so I have used it, and you multiply it. It's an easy process, and you get the utility score. And it varies from 0 to 1, 0 being the worst and 1 being the best, obviously. So 0 will be for the candidate who has a health profile of all the quintuple 5s, that is all 5s, and vice versa, all the 1s, that's quintuple 1s, will have 1 health utility score. So this is my ethics clearance. So coming to my results, this is a descriptive figure. It's a box and whisker plot. So it shows the age distribution of the study population. Here we can see the mean and the median is almost at 50. So my inclusion criteria was any candidate about 18 years, above 18 years, with any stage and site of cancer. So that's why we can see a wide range. So it starts from 25 to 74. So I'll go to my next figure. So next figure is a pie chart. So I given pink for men. I like pink. Okay, and the green is for females. Here we can see there is an equal distribution almost between both the genders. Almost 55% contributed by women and the rest by men. That's 45%. Coming to my next figure, that is also a descriptive figure. So it shows the stages of cancer of patients. Here we can see stage 3 has almost around 45% of the participants. Like 45% of the participants actually had stage 3 and almost 35+% had stage 4. This actually tells a story, especially in Southeast Asia and India. There is a late trend in diagnosing or the patient presenting to you at a later stage. And obviously, if the patient presents to you at a later stage, the quality of life of that patient will be depicting in a lower utility score, or a health profile that he is getting will be low. Coming to my next figure, that is another multiple bar graph. So this shows the distribution of participants according to the reporting problems. I already told the 5 dimensions that we were seeing, and this is not a not mutually exclusive. So it's like a multiple response question. So here we can see the pain that was reported by the patients was around 82%, more than 80%. Almost 159 candidates had reported pain, unmanaged pain. And the next most reported problem was anxiety. It came up to around 66%. So that is also a huge number, followed by mobility concerns, more than 55%, and self-care and usual activities getting hindered, less than 35%. So this shows the whole story. Unmanaged pain and anxiety, that is psychosocial issues, is a huge concern among the patients. That is not dealt at a tertiary care. The public hospital that I have collected the data from is a tertiary care hospital, and a tertiary care hospital is not able to do it. So I'll talk about this more in my conclusion, how we can deal with this. So coming to my next figure, so it's a box and whistle plot again, which shows the utility scores among the participants. So I have a couple of outliers that you need to focus. The one on the the bottom, that is 0.005. So there was a patient who had like really bad utility score because his health profile was really bad, obviously. So that, even though it's an outlier, only 1-2 patients reported really bad health problems. That needs to be seen. That needs to be focused upon. Why is that patient still having that health profile even though he's visiting a tertiary care health center? So this is my last figure. So my last figure is a word cloud. So it's a word cloud depicting the health profiles. So I made it into a shape of heart because heart represents good health, and it has an EKG also because good health will have a good EKG. So here I want to focus upon 2 to 3 things. The first one, all the quintuples, all the ones, and the 11121 health profiles contributed the most, around 8%, followed by 11122. You can see all the green ones, the big numbers with the green. That's what I'm talking about. So all the 11122 and all the ones, that is quintuple ones, contributed the most. And those patients actually had good health profiles and an overall well-being in association with health was good. But I want to focus on something. You can see one number that has been portrayed in red color. It is 42443. I think the 3 is not visible. Okay. On the center of the heart, right side. It shows a health profile that I was talking about on the previous slide. The utility score being 0.005 that patient's health profile is depicted in this red color. So I want to show how bad it was. So that's all about my results. So I'll come to my conclusion. So in India, I already talked about South versus North and the problems that we are seeing in North right now. So there is a huge potential for organizations as well as government to tackle the unmanaged pain and anxiety issues, which cannot be done at a tertiary care hospital, as we clearly see. And Kerala, a state in India, has already proven that community integration with NGOs and other organizations can help tackle the unmanaged pain and anxiety. So there is already a study that we can follow. So I would recommend organizations like MSF to do more cases, to do more studies in this field, as well as when we do HRQL integration into programs like health programs, national programs, or any at organization level where the researcher is saying where it's going wrong or right, HRQL gives us an idea of how or where we are leading or where the program is going. So I have a couple of limitations. Obviously, I'm a postgraduate student, so time was a constraint for me. And because it was a single-centered study with a really less population, the generalizability of the study is less. And I already told time was a constraint. So what I could have done on a larger scale was looking at it at a longitudinal way. Instead of looking at it a cross-sectional way, I could have collected the quality of health on a longitudinal way and how quality of life changes over time with treatment or with any other intervention. So that could have helped me calculate DALI as well at a later point, but that's a long run. So that's it. Thank you. Thank you, MSF, for having me here. And on a personal note, I actually joined post-graduation because after my MBBS, I couldn't join MSF because MSF requires 2 years of field practice. So I thank MSF for helping me do my post-graduation also. Yeah, thank you.
Yes, we need to thank MSF for making you identify this useful contribution on a score being developed. And it's interesting to note that, that you're looking at it in a prospective way, also a longitudinal way. As universal health coverage is now not only talking about numbers, but although quality is supposed to be embedded in it, now there is a growing focus on actually relating the universal health coverage to the quality aspects, and it's not just about how providers see quality, but the patients or the person's experience, and that is what we have also spoken of in these presentations, and of course the political commitment. Let's open the floor to some questions now if we have time. Yeah. Okay, we have about 10 minutes. Yeah. Questions or concerns or comments? Yes, please. Can we have a mic there?
Yeah, actually, I'm asking a question from Mulaz Zada. Yeah, this is regarding that quality of care in fragile. From based on your finding, what kind of policy changes do you recommend to implement that quality of care in fragile? What do you recommend? Any policy changes do you recommend based on your findings?
Dr. Abdul?
Yes, I'm hearing. First of all, what we are suggesting within the MSF, which works in over 50, 60 countries, to not compensate reporting, because you want to improve quality, then you compensate it with more reporting, with more data, and more reporting. That makes stuff overwhelmingly overworked, and it's hard to interpret and make any decision out of it. The policy change we want to propose, at least that's what we are working towards, is to make sure quality is not looked into one-sided, either only within program data or only from the one spot check of surveys. It has to be with patient, with communities, and a multidisciplinary side of it looking into it. So quality cannot be looked without patient and community being part of that improvement. And it's for long that quality has been prescriptive by the service providers. And this is the quality we think is good for you. And I think we need to move away from that. And we need to, nothing for us without us. I think that applies for quality improvement as well. And I think that is the policy change. The thinking, the approach need to happen.
Okay, thank you.
Okay. Any more questions? Everyone is tired? Or we have to have another clowning session, I think. Are we in for it? Or we'll go outside and clown, right? Yeah. Okay. Shall we call it a day? Yeah. So let's thank the presenters for sharing their research to improve the quality of care, empathy, compassionate care all around the world. Yeah, thank you.
Thank you, Dr. Susie Pereira and all our presenters for offering diverse insights into advancing quality of care across varied contexts, reminding us that quality of care is doing the right thing every time for the patient whenever they need it, at the time they need it, across the spectrum of healthcare, from prevention to curation to rehabilitation to palliation. And remembering quality is everybody's business. Let's not leave out the non-medics. And as Abdul said it, nothing about us without us. So we take the communities with us. As we close this session, let's carry forward the importance of person-centered approaches to healthcare, ensuring that quality care reaches everywhere to everyone. To close today's event, I now invite Professor Thoranga Thorandia, Director, Center for Planetary Health, Faculty of Medicine, University of Colombo, and Gada Khemesi, Head of Programs Unit, MSF South Asia.
All right. I thought I'll come second, but it's okay. All right. Hi, everyone, colleagues, partners. As we bring the day to close, I want to take a few minutes to reflect on the rich discussions we have shared today. Together, we have explored how communities adapt in the face of crisis and how the human cost of violence and fragility demands reimagining of quality of care. Care that goes beyond medical interventions to embrace context, dignity, and compassion, like my colleagues were just explaining now in the final panel. This morning, we were offered a powerful reminder that resilience is not a slogan, but a lived reality built every day by communities. We saw how a nutrition program in rural Sri Lanka integrated health, education, and infrastructure to improve children's well-being during the COVID-19 pandemic, proving that community ownership is key to sustainability and scale. We learned from Dhaka slums where female adolescents displaced by climate change face profound barriers to sexual and reproductive health, risk of early marriage, and how adaptive, equity-focused interventions can begin to bridge those gaps. We reflected on women in climate-affected areas of Sri Lanka as well, whose fertility preferences are shaped not only by personal choice, but also by shifting livelihoods and fragile autonomy that exposes them to gender-based violence. And finally, from Cox's Bazar, we saw evidence that group-based mental health interventions can transform maternal well-being and child health among displaced Rohingya communities. Across these stories, the message is clear. Resilience grows when responses are community-centered, context-specific, and inclusive of the most vulnerable. We must ensure that mental health and sexual and reproductive health are not just afterthoughts, but central to humanitarian responses. And we must link climate, health, and social policies to address the interconnected vulnerabilities that crises always expose. Today, we were also reminded that healthcare is never only about pills or protocol. It's about humanity and community, like Samrin just said. From Delhi and Mumbai, we witnessed how medical clowning in public hospitals is not frivolous, but profoundly therapeutic, reducing anxiety and reminding us that humor and dignity are part of healing. From Yemen, we heard from Abdul about the daily struggles of maintaining quality care amidst conflict, and how patients' perception of care often depend less on formal structures and more on their lived experiences with their caregivers. Again, from Cox's Bazar, the stories brought us closer to the reality of humanitarian palliative care, where empathy is a key part of the healing process. What emerged at the end of the day is that quality of care is possible in low resources setting and is not only limited to clinical setting standards protocols. It is shaped by compassion, context, and community. Taken together, today's sessions underline a shared truth. Health, resilience, and dignity are interconnected. We must design holistic, intersectional interventions and partnerships. We must place community ownership and participation at the center of our humanitarian interventions. We must recognize that empathy and compassion are not just soft add-ons, but essential pillars to quality of care. And as we move forward, let us commit to strengthen partnerships, champion compassion in care, and support local leadership. And let us remember that resilience is not only about survival in crisis, and quality of care is not only about treatment. Both are about creating systems where people can live with dignity, hope, and agency, even in the most fragile settings. And as we conclude the day, I would like to take a moment also to express my gratitude to those who made today possible. First, I would like to sincerely thank the Sri Lanka Ministry of Health, colleagues who joined us today, and for their continued support and partnership. I would like to express our deep appreciation for our partners, the Faculty of Medicine, University of Colombo, represented by esteemed Professor Vajira, and the Sarvodaya Movement Sri Lanka, represented today by its president, Dr. Vinya, for their unwavering support and collaboration in making this event a success. I want also to thank all the speakers, presenters, and participants for their valuable contributions. Your research and on-the-ground experience have really shed the light today on some of the most pressing issues in global health. And I would like to deeply thank the editorial committee of the MSF South Asia Scientific Days 2025. Some of them are present with us today in the room. Your hard work to ensure the relevance of the topics was key to the success of the day. I would like to also thank Samrin Hussain, who had been our excellent day chair today, and for guiding us with such clarity and connecting the different sessions. Thank you so much, Samrin. And a big thank you also to the comms team who's sitting around this table. Nadim, Deepak, Stefano, Dilmini, Sasanka, many others. Thank you so much. Some of you stayed to 3 a.m. I think yesterday to set up the room, so thank you so much for all the efforts. Yeah, please. A huge thank you to Kirti Kitu, if they are with us in the room, and the wider logistic admin finance team of MSF who supported us behind the scenes. And finally, I would like to thank the MSF South Asia medical team, Dr. Shivanti, Dr. Lahiru, Dr. Prashani. To Sita, your leadership, coordination, commitment had made this day this big success. So thank you so much. It's not possible to name everyone, so sorry if I forgot some names, but I would like to thank every and each one of you who contributed to the event. And sorry, because we were swapped, I think, so that was supposed to be the final thanks, but then I leave the space to you to continue maybe the closing remarks.
Thank you. Sorry about the swap. No worries. I'm trying to, highlight the key messages, takeaways from session 1 and 3. So it's my privilege and honor to deliver this part of the closing remarks on behalf of the Faculty of Medicine, University of Colombo, the academic partner of this inspiring MSF Scientific Days event. So as the academic partner, as Professor Vajra mentioned earlier in the morning, we are pleased to have this opportunity to share our expertise and learn from this diverse group. We are committed to collaborating on essential areas that are crucial for the next generation of medical practitioners, researchers, and leaders, extending our role far beyond medical education and patient care. So today's proceedings, starting with the thought-provoking keynote, provided us with new perspectives on how to tackle the challenges we face, the complexities of modern medical crisis, including the health challenges related to climate change, that demand more than just a new approach. They require us to rediscover and redefine our understanding of humanity and success. The presentations we just witnessed, have not only showcased robust research, but have also served as a powerful reminder of the human element, as we are discussing the human element at the core of our work. As Professor Devi Vijay, in her keynote, discussed the concept of disposable population, whose bodies serve as toxic sinks, a radical call for a new form of care that acknowledges the profound inequities we face, which is crucial. The discussions resonate deeply with the ethos we uphold as an academic institution, Faculty of Medicine, Colombo. And I will highlight the key takeaways from session 1, empowering the unsung companions of care, a way forward in health workforce management, and session 3, co-creating health, community-centered healthcare delivery solutions. Session 1, we heard inspiring accounts of resilience from the Aragalaya street medics who brought sanity amidst chaos, to the invisible struggles of ASHA workers, and the mental health interventions from Sri Lanka, India, and Bangladesh, including innovative low-cost psychological support systems for rural healthcare workers. These are not just academic case studies. They are real-life experiences that demonstrate powerful human-centered interventions that can be adopted and scaled. This includes exploring the new model of care, like our Bangladesh colleague has discussed, which has reached into the primary health care in Bangladesh. These accounts highlight the incredible capacity of individuals to provide care even in most unpredictable, challenging circumstances, as during Aragalaya. During session 3, we examined community-centered healthcare initiatives from mapping visceral leishmaniasis for sustainable elimination in Bangladesh to adolescent-centered healthcare in Zimbabwe, as well as addressing the overlapping risk of drug use and HIV in prisoners in India and stigma faced by women with drug-resistant tuberculosis in Mumbai. So these work provide invaluable models for transforming participation into power. It's clear that moving beyond clinic walls and into the community is not just an option, but it is essential for creating sustainable health solutions. So at this moment, the world is increasingly seeking wisdom, particularly looking into the East. So they look for skills in resilience, well-being, and community-based solutions. So as a passionate group in this region, we are uniquely positioned to share our wealth of knowledge and experience for the benefit of all humanity. The innovative competencies needed to solve today's problems, which are very, very complex as we know, are not always found in new technologies. Sometimes they are unearthed by exploring and revitalizing traditional methods and skills. So let these lessons from these sessions we had today inspire us to continue co-creating healthier, more resilient world. We are looking forward to our ongoing collaborations with MSF. Thank you.
This week, celebrated as Patient Safety Week, and today's event are reminders to celebrate and utilize this enhanced awareness towards meaningful improvements in patient safety. On behalf of MSF South Asia and the Faculty of Medicine, University of Colombo, and Sarvodaya Shramadana Movement Sri Lanka, we thank you for your participation and insights. With that, we conclude MSF South Asia Scientific Days 2025. We would like to invite you for some refreshments. Don't forget to explore the innovation kiosk and the exhibits, as well as the posters on digital display in the foyer. Safe travels and see you at the next Scientific Days.